Well, I'd like to welcome everybody to the 16th annual Spine Symposium Surgical Skills Lab. We've actually been doing this longer than 16 years because as a resident, I started this, although it was done haphazardly over at the old med school and in the old anatomy labs, which was pretty fun, but also smelly and greasy and gross. So this is much nicer now. I'd like to give Dr. Dempsey a big thanks for continuing to support this and working hard to get us lab space, and of course all the staff to help coordinate these things, because it is a heavy lift, and it's gotten a lot easier since we've gotten help. I've gotten help with this rather than doing all the phone calling myself. I'd like to give Dr. Dempsey a moment to say hi.
Yeah, I just do want to thank everybody for being here. And mostly, as you know, the staff that do all the work, they're invaluable. But it's so important that you're taking this seriously. Just pause a second, think about this topic, because 80% of your high school classmates are going to miss work during their life because of this. And the other ones just don't complain much, because we're all going to suffer from this disorder of one way or the other. Some tragically, some chronically, and we can do better. And so what we deal with are things of intense importance to our patients. And that's when your work is most actualized. So taking this seriously is the first thing we're doing. I thank you for that. I really thank, Than, who literally as a resident said, we need to learn more about this. And I said, fine, you're teaching it. And we'll get the equipment, we'll get the things, we'll monitor and so on. And it was pretty clear that it was just going to run free and run well. And it does. And a whole generation of people are growing up knowing that we take this disorders of the spine seriously and we can do great things about it. And that's what you're going to learn. And that's really the excitement of being here. So I thank you for being here. I thank our patients for inspiring us. And mostly I thank the staff for doing all the work. So thanks. But then thanks for doing this properly.
Thank you very much. Appreciate it. Thanks, Dr. Dempsey. Okay, and so with that, we'll kind of get going. Of course, this is our department. It's gotten a lot bigger over time as we've gone from one resident a year when I started to 2, and now 3, upcoming 3 residents a year. So we'll start to look like an orthopedic surgery program someday. And then, of course, we've got quite a few presenters coming today, and I definitely try my hardest to get many different disciplines of spine care involved, because I think that's really important to think about when you're learning and also when you're practicing. I think it's really critical to think about spine problems holistically. Sometimes, actually, I've been hardly ever surprised to see, if I ask somebody an open-ended question about how their life's going, you realize that most of their back and neck pain is coming from some tragedy in their life or some stressor that has nothing to do with the findings on their MRI scan. Of course, we can't do this without the companies helping us out with some of the equipment, and certainly some of the deferring some of the costs of cadavers and fluoroscopy and things like that. So I'd really like to thank Medtronic, SI Bone, and Stryker. Of course, you'll get a chance to use some of their stuff today, and then also tomorrow during the lab. And I think that's, of course, a valuable partnership because we kind of use implants and companies along with our own skills to take care of patients. So it's really important to get a handle on those things. And that's a lot of what this lab started as. Back in the day, it was really a way for us as residents to kind of get our hands on the equipment and learn how to put it in and do it safely and learn the anatomy. And I think that's really, the focal point of all of this. And even tomorrow when we're doing fluoroscopy and working on early on, we'll be doing injections and things like that. That's still an anatomical procedure. You have to understand the anatomy in order to do it safely. So whether it's a surgeon or a rehab doctor or an anesthesiologist, you still have to understand the anatomy and do it safely. And that's the critical part of the technical part of this. And today is going to be more of the cognitive part, which I think is important. You may get a picture taken of you if you don't want a picture taken of you, which only applies to like the later generation, I think. then we will we'll let Janelle know. We all start on different rungs of the ladder as far as education goes. Some of us start as experts, or some of us are experts at this point, and some of us are still very much in the beginner stages. And of course, in surgery, that takes you through a cycle of being very much a beginner, where you're dangerous to a point where you're relatively competent, and then later on, as you become an expert, you become efficient. So the competency can be relatively slow, but you're still safe, whereas efficiency comes at a later date. And it's a cycle. You certainly are going to learn both by doing and by listening, and then by talking, and all of these things come along with mentorship. So you really have to listen to the people who've done it before you and try and learn, and then of course practice and do it in a safe way. As residents, you're practicing under supervision, and you want to take that opportunity to pretend like you're doing it for real, but have somebody tell you that was a bad idea, right? So you really want to use that opportunity to help organize your thinking, make sure you're not making errors, and make sure you recognize what's safe and those kinds of things. So you want to take that seriously, like Dr. Dempsey said. I wrote down as many subspecialties as I could, and this is, I don't think, is technically a large enough list yet, because I left out emergency medicine, which is a huge component of back pain, of all the different specialties involved in spine care. I think when you realistically look at this, it probably could be one of the more complex and complicated parts of the human body to take care of, just from a subspecialty perspective. So it's very important to keep that in mind as you're taking care of patients, depending on what their pathologies are, that you're going to be taking care of them as a team as opposed to an individual, and that just one procedure may not be enough to get them back to where they need to go. With that, we have today's agenda. We can't learn it all. We do have a course that runs about a week in Cleveland that tries to teach you it all, and in fact, you can't even learn it all in a week. So we try to pick a couple different topics depending on the year to talk about, and we'll start out with cervical radiculopathy, and we'll move on to rheumatologic disease or spondyloarthropathies and talk about that a little bit. Get a wonderful professor's lecture from Dr. Tribune, who I'm not going to say he's going to retire, but someday he will. And so we want to hear his thoughts, and it's really good to hear, certainly from people who've been doing this for an entire career, what they really feel is important, because I think that sometimes can be lost when you're first starting out. You'll think that being important, the most important thing is to do as many cases as possible, as quickly as possible, and later on you start to realize that maybe it was something slightly different than that. So very important stuff. And we'll talk about complications at the end, which always inspires a lot of good conversation and learning. So I think those are really good things to talk about to get a better idea of not only what you can do right, but what you might do wrong. So avoiding that. We will be having an educational networking event later after that. So from 5 to 7:30, if you're available, please come down. I had no idea there was a nice bar at the Fluno Center, so we're going to be going there. It's on the 8th floor. It gets nice views of the city, and we can spend some time talking a little bit more about what we did in the symposium, and kind of get ourselves primed up for the next event, which is tomorrow. And tomorrow, again, this will be up in our lab, so a slightly different space. For those of you signed up, of course, we did need to know in advance, because we have to get lead and all the other things to make sure we can keep people safe. We're going to have fluoroscopy in the morning, along with some open procedures, but mostly fluoroscopy, trying to learn how to target with fluoro. And then in the afternoon, some of the open surgical procedures. And again, historically, we tried to break this up over 2 days, but we realized that we really lost a lot of participants after day one. So we moved it to a big marathon, 1-day event. This is what the lab space looks like without the cadavers, of course, and you can see where we're going to be. We have to use, some of the cadavers have to be on simple plywood and sawhorse constructs, so you can do fluoro. Those tables will look a bit odd, but they'll make sense when you see them tomorrow. And then you can see Dr. Trost who is one of our newly retired faculty who's spending a lot of time educating and doing a great job. And we try to do that with all of our junior faculty and senior faculty, as many as can attend for a Saturday. It gets kind of wild. So we've got, this is on the left of the picture as a faculty from Bolivia. We have an exchange program with Bolivia that we do with bringing them here to learn some of our newer techniques and get some experience. And then of course, this is one of our residents who just kept learning until his gloves tore apart. So he's a good example of how much you want to work throughout the day and really get yourself as much experience as you can in the lab. So thank you everyone for participating. Again, if anybody's interested, and I know we're going to be recording this is why we have this, but also anybody in the room that's a resident or knows residents who might be interested in neurosurgery fellowship and spine, this is the link for that. So, and with that, we're going to bring up our next presenter, who will be Kath Pride. We're going to be talking about cervical radiculopathy and treatment of that. Cervical radiculopathy, of course, is pinched nerve in the neck, and we are seeing this commonly. And so there are a lot of different options for treatment. We want to talk about the non-surgical ones first.
Good afternoon. It's a pleasure to be able to present here, discuss some of my knowledge and knowledge that has been given to me, and so I can share with you guys. I don't necessarily have a lot of history of mistakes that I'm showing that I've corrected or learned from. This is more of a basic look at cervical radiculopathy and then its non-surgical treatments. But there aren't too many, but there are some that certainly are life changers and some that we do very commonly and make up the brunt of our cervical interventions as far as pain management. So again, I'm an anesthesiologist here. I'm one of the few who does 100% pain from our department. But again, yeah, thanks, Dan, for allowing me to speak today. So I don't have any disclosures today or conflicts of interest. So. Our objectives are simple and few. We're going to review some non-surgical or also known as interventional techniques to help with cervical radiculopathy, and then review a little bit of the evidence supporting these decisions and interventions. Radiculopathy, solely as a presentation, can come from several different things. The underlying thing typically is an irritation or squeezing or a compression or stenosis of the cervical spine or one of its branches. This can be due to several different things. Disc herniation, probably most commonly. Overall cervical stenosis from a multitude of things presenting with radiculopathy. Associated diagnoses like cervical spondylosis can be present either as an underlying cause, as you get swollen joints that contribute to the stenosis, or something as a bit of a red herring. Is your pain coming from this arthritis present, or is it coming from nerve irritation? So. And then lastly, post-laminectomy syndrome, or as insurance companies like to refer to it as a failed back surgery syndrome. I'm not going to concentrate too much on this, but oftentimes you get radiculopathic symptoms associated with this. So I thought I would just include it very briefly. So we have to talk about the patient's presentation, right? How long had they had this pain? Was there a history of trauma, or was it just by happenstance? Was it gradual and insidious? Had they had a surgery or previous injection before? Is it relevant? How long did it last? Did it work well? Is this something that's worthy of repeating? Are they a true virgin to interventional pain and or surgical evaluation? Have they done physical therapy? Are they being medically managed? All these things. And they have to be taken into account before making pretty much any decision as far as their treatment path and management before jumping into doing something like needlework or epidural steroids. But that's something that kind of goes through our head as soon as we evaluate somebody. All these boxes have to be previously checked so that we kind of meet that criteria of most conservative management first, which is why I'm here speaking with you at this neurosurgical symposium, right? It's we're what we do, or who you turn to if surgery is not an option, or is not an option yet, or the pain isn't that bad, or there's not significant motor loss or things like that. So what's their presentation, right? Is there generalized neck pain? Is this widespread? Is it isolated in the neck or one of the upper extremities? Is there obviously accompanying radicular pain? Do the patient also have paresthesias. Is this from cervical radiculopathy or is this from something else? So it's important to try and weed this out. Could this be CRPS or some other polyneuropathy? Are there other associated symptoms? There typically are muscle aches, sometimes headache if you have cervicogenic spondylosis, which isn't necessarily radiculopathy, but very commonly patients present with a whole host or multitude of symptoms, and it's up to us to kind of tease out what's most debilitating for them, what is intervenable upon, and what has the indications for us to take action, right, beyond medication. Are there interventional options? So what's the goal for intervention? Basically, it's almost always just to provide pain relief and improve their quality of life and their functionality. Sometimes we'll get a referral from neurosurgery to say, can you identify a certain level by doing an epidural steroid, maybe just with local anesthetic instead of steroid and local anesthetic? And in that case, it also carries this diagnostic purpose behind it as well. Whenever we're doing this, we always have to consider what area we're targeting, what level. Should this be an interlaminar approach from midline, or should this be more transforaminal, targeting one of the specific cervical spinal nerves, C6, C7? Interventional management. When they present with this radiculopathy, what other options do we have, or what should we include in our evaluation? Do they require an EMG? Have they had a neurosurgical evaluation? Again, what approach should we take? And is this something they've had in the past? Should this be repeated? Why should it be repeated? And are they, or when should it stop being repeated, right? This only lasts for 2 months. Should I get another one? Doctor, I don't know. Did you get increased functionality? This only lasted 2 weeks. Should I get another one? In that case, we're probably going to consider something else. So epidural steroid injections, I'm going to talk a little bit about this because this is probably one of my most utilized pain management procedures, but also worldwide, the same thing for cervical and lumbar radiculopathy. Its use is supported by more than 45 placebo-controlled studies and also dozens of systematic reviews. Probably more now. Despite this extensive literature, there in green, there continues to be controversy surrounding the safety, but also the efficacy of this, especially in the long term, in patients getting these cumulative levels of steroids if they get them more than 3 to 4 times a year, especially in the same space or same level. It should be noted that the results of a lot of the clinical trials are heavily influenced by specialty, interestingly, with those done by the interventional pain physician world more likely to reveal positive findings. And there's just some pictures there of cervical epidural approaches to steroids. Those are just contrast levels being injected. This is a pretty large study. It's a retrospective analysis. It's the only one I'm really going to go to today. It involves over 190,000 patients. There's an inclusion criteria. Basically, they had to have disc herniation or stenosis or radiculopathy, over the age of 18, enrolled for a year. And what the results of this were that within 6 months of a cervical epidural steroid, about 10% of patients underwent surgery. This increased to about 15% by year 1 and over 20% or 22% by year 5. Male patients and those aged 35 to 54 had an increased likelihood for receiving surgery after epidural. And then patients with comorbidities like CHF and other cardiac comorbidities or chronic pain were less likely to undergo surgery, as were, interestingly, again, patients of the Northeast U.S. region. Patients who underwent or are undergoing repeated injections were at lower risk of receiving subsequent surgery. More about the approach. So interlaminar basically is just that. Essentially, it's midline. It can target or cover sides, both sides if a patient is having bilateral symptoms. When comparing it to the lumbar spine, the ligament inflatum is quite thin or thinner, making this a more dangerous or relatively riskier procedure, especially the higher you go in the cervical spine. Transforaminal approach is even less commonly performed among pain physicians, and this is due to a further increased risk. The literature reveals or has revealed a number of rare, potentially catastrophic sequelae done or received by some of these patients who historically had received particulate steroids, something like triamcinolone or Kenalog. Most of these were thought to be due to some sort of intravascular uptake. There are very, very few providers, I think, in my department or PM&R pain that use particulate steroids when doing any approach for epidural steroid injections, but it's something that should be noted. And always, obviously, we take great care whenever taking that transforaminal approach. A way to minimize complications is to use a test dose of local anesthetic before doing this, and then obviously avoid the particulate steroids. So. Field back surgery, I'm only going to do this for about 1 minute. Basically, it's long-standing. It's when a patient has ongoing pain even after surgery, and we have to find out a way to treat now this either the same or a new pain, whether it's radicular or other. And one of the primary treatments for this is spinal cord stimulation or intrathecal pain pump, the former being probably more common, but significantly less so in the cervical spine when compared to the lumbar spine due to anatomy as well as some other challenging factors. And then lastly, dorsal root ganglion stimulation, which is even less common. Again, this diagnosis is more easily attached to lower back pain, but it still exists in the cervical spine. It's likely spinal cord stimulation are probably more commonly placed for things like complex regional pain syndrome of the upper extremity in the cervical spine, but just something of note, it's one of the interventional options we do have for something like this. So that's all I've got. I didn't mean to talk too fast. I know I just wanted to cover a lot of material relatively quickly, and I'm happy to answer questions if you want to do that. Otherwise, we can step on to the next.
We'll have time for questions at the end, but thank you very much, Kath. We'll get into that, and I have quite a few myself because this is an interesting side, things that we don't do as often. So it's important to get your opinion while we have you. So you can sit like in the front row or whatever, just as long as you're available for.
Yeah.
Great. So next speaker, Dr. Jim Bernatz, who is an assistant professor in orthopedic surgery, one of our newer, not that new anymore, but newer spine faculty. We're looking forward to hearing his perspective on anterior approaches, which is not the only approach he does, by the way, but it's just what we're
If I had my choice,
learning
it would
about
be.
today.
Thank you, Than. I appreciate it. While my talk's getting loaded, hello, everyone. I'm Jim Bernatz, one of the orthopedic spine faculty. I have the distinct pleasure about talking about anterior cervical approaches, which actually I do love, to be quite candid. This is a topic I'm passionate about. I usually have to start a talk by trying to sell it to the audience of why this is important, why I care, but I think you'll hear when I talk about this one that I actually do love this one, and I do care. Thank you. All right. I have no pertinent disclosures for this talk, but as I said, I think if I had to pick one spine operation to do the rest of my life, it would be a single level ACDF. So know that my bias is worn on my sleeve right now. So I'm going to go over a few things regarding the anterior cervical, both exposure and surgery options, and you'll hear kind of why I like each of these facets of the surgery. So we're going to talk about the anatomy of the anterior cervical spine briefly, talk about the ergonomics, the actual nuts and bolts of performing the operation, talk about the postoperative recovery for these patients, and then we'll explore the breadth of pathology that the anterior cervical approach can treat. We'll talk about the motion preservation that you can still achieve with anterior cervical surgery, deformity correction for those who need it, and then briefly we'll touch on the outcomes literature, which essentially I'll propose to you that there's equipoise and you can choose if you want to go from the front or the back for a lot of things. So first, anatomy-wise, the reason I love this operation is because this is our chance to actually be surgeons. Most of the time, my surgeries go knife, bovie, burr, screw. That's pretty much it. But this, I get to ask for like a Metzenbaum scissors and a pickup, which is unique in spine surgery. It's delicate, it's precise. The platysma doesn't count, so we don't really cut any muscles in doing this operation. You feather off the longest coli, so it's really quite beautiful. Really minimal blood loss despite doing multi-level operations in some cases. And sometimes you're looking at a patient in clinic and you're looking at the front of their neck and the back of their neck, and the front of their neck can look a lot more appealing than the back of their neck. Ergonomics. Positioning for anterior is just better. The patient slides over onto a flat top table. They put them to sleep. You put a roll under their shoulders and you're good to go. Positioning for posterior surgery, I find incredibly painful. You put them in the Mayfields, you got to flip them, and then their chin isn't right, and the chest pad's too high, and then you hook up their head again, and then you take it off, and then you hook it up again. You tape their shoulders. It's terrible. And then here's a recent case of me and our fellow Sarah doing a posterior cervical foraminotomy, and it almost looks like we're inducing a cervical radiculopathy in ourselves just trying to do this operation. So ergonomically, much less enjoyable. Postoperative recovery. So that guy, Peyton Manning, has had both of these things, both posterior cervical surgery and anterior cervical surgery. And I think any one of my patients would tell you that anterior cervical surgery hurts much less than posterior cervical surgery. Everybody hates posterior cervical surgery, so I much prefer doing the anterior. And these tend to be my happiest patients. At the 3-month post-op visit, I ask them, hey, how you doing? How's life? And I get all the time, like, I don't know, I kind of forgot I had neck surgery. Don't really think about it anymore. Whereas that's not the case with posterior cervical surgery. Wound infection risk, so much higher in posterior cervical surgery. I just washed out 2 posterior cervical necks. Last week I was on call. I've never had an infection in the front of the spine, knock on wood. And then overhead lifting. So I'm much more cautious with these people that I've done posterior cervical surgery on, because I take it personally offensive if they come back to clinic and they have that scooped out fascial dehiscence that didn't heal. So I'm really cautious with how much I let them lift in the early postoperative days, two-handed lifting, et cetera. Whereas front of the neck cases, I kind of let them do what they want. Breadth of pathology here. So this is where I think anterior cervical surgery really shines. You can cover a lot of ground from the front of the neck. It's really kind of a workhorse operation. You can take care of disc herniations that are both central and foraminal. You can do calcified discs, more of the arthritic disc osteophyte complex. If it's just solely from collapse and from foraminal stenosis, you can restore that height. You can take care of multi-level disease, 2, 3, 4, 5 levels from the front. And really kyphosis, spondylolisthesis, really well suited for anterior cervical surgery, which can address both sagittal and coronal deformity. Motion preservation, right? Obviously, we want to preserve motion if we can. And up until about 20 years ago, that wasn't possible with anterior cervical surgery. But now we have 20-year follow-up data on some of the cervical arthroplasty devices. There's a bunch of companies that have 1-level arthroplasty devices. There's 4 companies in the United States that have 2-level indications for their arthroplasty. And then if you just go on Instagram, you'll find that you can get as many discs replaced as you want. If you live in San Diego and you pay cash, you'll find x-rays like this all over the internet. Deformity correction. So just like in the lumbar spine or the thoracic spine, the anterior column is a really powerful tool for restoring appropriate alignment. So if somebody has both a combination of cervical radiculopathy and they've got an alignment problem, 10 out of 10 times I'm doing something from the front of the neck and sometimes in combination with a posterior surgery. From a literature perspective, like many things in spine surgery, you can really argue it both ways. You can stand up here and say that foraminotomy is better. You can stand up and say ACDF, ACDA. You really can pick what you want to present here. I'll even say here with this large study here that looks at arm pain 1 year after surgery, that foraminotomy was non-inferior to ACDF at 1 year out. But this is kind of my favorite piece of literature as it applies to anterior posterior cervical surgery. And this is a big study by a lot of smart people. And my favorite finding that they have here is that the 2 procedures were found to be offered to different populations, with ACDF being selected for patients with more complicated pathologies and symptoms. So you can just cover more ground with something from the front of the neck as opposed to a posterior approach. And so if I'm choosing to focus a practice on what I can get good at, what I can treat more patients with, I'd much rather select an anterior surgery to get good at rather than a posterior surgery, because I think you can just treat more complicated pathologies. And it just so happens in this study that ACDF performed a little bit better than foraminotomy. So again, kind of highlighting the equipoise that's out there in the literature. So in summary, I find the anterior approach to be muscle sparing, certainly less painful. I think it's fun, it's ergonomically comfortable, I love doing it, I love teaching it, and really it's a powerful tool for multiple pathologies in cervical radiculopathy and beyond. Thank you very much.
Thanks, Jim. Appreciate that. That was great. So looking forward. I didn't mean for this to set up as a debate, but it kind of did.
I didn't mean to either.
No, it's okay. But from let's see. Thank you for that wonderful overview. And let's put Brad up here. We'll get his perspective, and then we'll go through some cases. Perfect.
Oh, lovely. Thank you. All right. I'm Brad, one of the neurosurgery faculty here, specialized in minimally invasive and complex spine. Been here now, going my 3rd year. I think Jim and I started at the same time. So it's been good. It's been fun. And Jim and I are always bouncing ideas with each other, which is great. So it's really fun to follow him with this. And he got the fun one. The anterior, I would agree, is probably one of my favorites. And I would also agree that they tend to do the best. But let's talk about the posterior, because sometimes anterior isn't an option or isn't the best option, right? I am a consultant for endoscopic spine, which I do bring up for a second here at the very end. We're going to skip all this. I can't have a talk without talking about my family. Those are my kids, Haley, Miles, and Maddie. My wife, Kelly, she's an interventional cardiologist here. She's busy in the cath lab today, much smarter than me. If any med students in the audience ever want to see the cath lab, you have an in now, just let me know. My other kids are the residents that are constantly. This is the reason I love this job and here at academics. I love teaching and having residents there, especially when BJ on the right, I'm not sure he's really even working in the OR there, just throwing up peace signs. All right, so today we're going to, cervical spondylosis and issues with neck pain and radiculopathy come in a lot of shapes and forms. These are just varying types of pictures, disc herniations, horrible, congenital pathologies, huge overgrown osteophytic changes. Like, these are things that can all affect, the spine, and again, can go into your factors. Do you go from the front or the back? So the way I always break it down in clinic is, what's the problem, right? Today we're focused on radiculopathy, and that's the whole point. But myelopathy, right, just as a quick refresher, is typically bilateral. It's upper motor neuron signs. It affects the hands more than the shoulders. Balance can be an issue. Whereas radiculopathy, again, this is the whole focus, typically unilateral, although we've all seen radiculopathy where it can be bilateral, depending on the disc or multiple levels or whatever. It typically follows the anatomic path down the neck into the arm and hand. It's dermatomal, right? And it's lower motor neuron, so hyperreflexia, so something to remember there. A lot of different cervical options. Obviously, Dr. Bernanke just went through all the anterior. We're going to focus on the posterior today, which quickly just involves typically laminectomy, laminoplasty, lamifusion, foraminotomy, and then obviously you can, any of that sort of with an open versus MIS, right? That really adds fun and complexity to it. There are guidelines with this, right? That in essence, we don't need to read all this, but in essence, laminectomy, laminoplasty, lamifusion, they're all effective, right? They all decompress the spine. If you're really not worried at all about long-term stability, then laminectomy is probably okay. If you are worried about long-term stability, lamifusion is your best option, right? Makes sense, right? Laminoplasty is that really nice middle ground, though, where you preserve some motion, although you lose more motion than I think we sort of probably give it credit to. But it is motion preserving, especially compared to a fusion. But you still get a little bit of stability, safety with it. Again, not as much as a fusion. So you can think about it like a spectrum. This just talks about foraminotomies, that they work, and that the classic study that shows by old chair here, Dr. Zadeblik, who found that you can take about 50% of the facet joint unilaterally and not destabilize the spine. So that's where that came from, just for what that's worth. I'm going to skip a lot of this data because it's more fun to talk about cases, which is what I have here. So this is a 60-year-old female with extensive C-spine surgical history, including multi-level ACDF with a bad pseudomeningocele. Ended up getting a corpectomy, a big anterior fusion, and now has an acute adjacent segment right below it, C8 radiculopathy at C7-TU1. She had a great response to an injection on the right side. Here's how she looks now. What's really interesting about this, you can see all the surgery she's already had. Look at that bottom right corner. This is a really cool picture in a bad way. That's a pseudomeningocele completely highlighting the fibular graft, right? You see that? So this triangle here, that's the fibular strut. That's completely highlighted by CSF. Right? Now she's stable with that, which is great, good for her. But if you look at this top left image, the top right image, right? Her adjacent segment below, that's the disc in question. And here's the axle cut through that, right? You see on the right side there, a large disc herniation, right? And the left side, the frame is way open, but this right frame is really, really tight, right? So you could go from the front, but if you go from the front, you're going to hate your life for the next probably 10 years because you're going to get into that pseudomeningocele, right? So could you do something from the back? So that's what we did, right? We did a MIS foraminotomy, but then C7-T1, no one's favorite, right? Because this is the view you get, right? How do you know where the heck you are, right? And so this is one learning point I wanted to bring up outside of just doing the foraminotomy is not the right answer, but one of the right answers here, is what do you do, right? You can oblique. You oblique your fluoro, right? So if you oblique your fluoro, then you get this view. And suddenly, if you look at the image on the right, you can start counting the lamina. You see down the lamina because you're shooting around the shoulders, not through the shoulders. And so now you can see that your tube is at 7-1, right? And so there's always a way to get there. You just have to get creative. You could use O-arm if you really had to too, but this just shows that. So now, when I consented her for the surgery, I was still worried that there was a risk I could get in that pseudomeningocele, believe it or not, right? Because it's epidural, right? I'm going to be opening the epidural space. Thankfully, we did not, but I talked to her about that, and she was still wanting to take on the risk. Next case, 63-year-old female, bilateral arm, numbness, tingling, weakness, dropping things, difficulty buttoning shirts, balance problems, right? What does that sound like? Myelopathy, right? They're myelopathic. There's their image, right? So, we got 4, 5, 5, 6, 6, 7, kind of 5, 6, 6, 7. The bottom two levels, maybe 3. levels of stenosis, signal change myelination, the spinal cord there. Bad, it's mostly anterior, right? It's all disc bulge, right? So you want to do a 3-level ACDF? What else should we get maybe? You don't have to, but what else could you get to see if your ACDF's a good option or not? Or if you got a CT, right? So what does that CT show, right? Huge overgrown osteophytic changes, probably OPLL, some calcified dura, right? So the last thing, not the last thing, because a lot of times if you're careful, you can still potentially get through it. But if you want to be extra careful, going from the front, really high risk for spinal fluid leak and gerotomy because of calcified dura and overgrown bone. So you go from behind, right? This is a perfect case for a laminoplasty, right? So you go from behind, you sort of pop open, fracture open the lamina, and put a little titanium bracket, that's what you're seeing there, to hold everything open. So this is that really nice middle ground between a fusion and versus a laminectomy where you still get some stability, but you still get generally motion preservation, right? All right, next case, 57-year-old female, previous ACDF, has now really bad mechanical neck pain and radiculopathy in the right upper extremity and some subtle myelopathy. Here's her MRI, right? You can see the previous hardware ACDF on the sagittal view, right? Look at the level below. Look at that anterior subluxation there, right? It's really fallen off. Outside hospital wanted to try an ACDF. I'll tell you, I didn't include the x-ray. That's substernal, so good luck. No, I mean, you can do it, right? You do a little sternal window and try to get in there, but again, it's gonna be really a challenge. So you can, another option, oh, there's the x-ray. Another option is you can go from the back. Now, obviously, the downside to this is a way bigger, right? To Dr. Bernance's point, right? This is a much, 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 much bigger surgery than just doing an ACDF level below. But this is just to show that this, obviously, right, this achieves the goal, right? You get decompression, you do your facetectomy, completely open the frame, and you can fuse across it. Then the last one I want to talk about is an MAS cervical laminectomy here. So this is a 74-year-old male, previous ACDF, now has new bilateral upper extremity numbness, tingling, weakness, again, more consistent with myelopathy, some subtle radiculopathy. Was desperately afraid, had a bad experience with his past ACDF, did not at all costs want another one, right? Because you could look at this image, you see on the sagittal on the left, the previous hardware, and the level below, right? At C5-6, stenotic, right? Absolutely ACDF in any other situation is a very reasonable thing to consider. But again, this patient did not want it, right? So what could you do? He doesn't want some more big fusion. So what if we did a minimally invasive laminectomy just to target that little level right there, right? So as I used an endoscope. So we dropped an endoscope in posterior. That's the fluoroscopy shot there. And this is sort of the view you get with that decompression. Top screen left is as you first drop the endoscope in, you see a little bit of the muscle, you see some ligamentum flavum, and then this is some lamina that you're seeing sort of coming through here, okay? Top screen right, that's after the laminectomy has been completed. You can see the medial edge of the facet as we drill it away, and all that sort of up there is the dura, right? So you get that whole laminectomy, whole decompression without really any major instability risk, hopefully. And this is their incision after that, right? So you've done an entire laminectomy in the cervical spine, that's their incision, right? So that's kind of the cool thing about that. That was a lot of cases, but cases are more fun than just shouting graphs at your face. So questions about any of that?
Perfect, Brad. Thank you very much. If all the speakers could come down, we'll ask all the questions and we'll go through some more cases. So that'll be perfect.
Great. So again, thank the speakers here for giving a lot of information in very short periods of time. That's actually much harder than the opposite, as it turns out. For medical students that are here, I just want to remind you that there's a whole host of treatments that we do before they ever get to this part. So remember, with the conservative treatment, especially for cervical radiculopathy, for 6 to 8 weeks, that includes physical therapy and NSAIDs, will oftentimes lead to good outcomes in about 80% of people. So we are, by the time they get to surgeons, you're seeing like a small cohort, and even Kath may see a lot more of those patients because they're kind of in the pain management and recovery phase. So that's important to remember. So we're going to start with this first case. This is a 25-year-old with a right-sided C6 radiculopathy. You can see on the MRI scan here, they have a right-sided disc herniation without any central stenosis or cord compression. The symptoms have been going on for a good 6 weeks without recovery from PT and et cetera. And very concordant with the exam. So positive Sperling sign, decreased sensation of C6 dermatome.
a little bit of weakness with wrist extension and bicep, and then the bicep reflex is less than the other reflexes. So very classic. Kath, let's start with you. So patients, let's say they're like a 4 out of 5 strength, and they've been sent to you just for treatment options. Would you consider an injection in this one? Yeah.
I'll consider it for sure. I mean,
Yeah.
can you guys hear me?
Oh, please use the mic just so that we're recording this so that yeah, it can just be in front of you. Sure. There we go.
There you go. Is that good? Okay.
That's good. Perfect. Yeah.
I love the word consider because, of course, I'll consider it. Will I do something interventionally about it? I think obviously the answer is depends. A workup or a full workup is now required, depending on how much physical therapy and what the physical therapy actually was. Was it formal or was this just the exercises that the 25-year-old downloaded from, I don't know, ChatGPT, open evidence maybe, the new Google. Yeah, so medically managed. I hear his strength. I'd like to know how much disability he actually experiences. Like how much is this affecting his daily life? What's his functional capacity like, and how much is this actually like causing pain for him? So I will certainly consider a surgical consult, especially if it continues to worry him and cause ongoing weakness. I'll prescribe the typical medications like NSAIDs, and depending on his neuropathic symptoms, something like a gabapentinoid if he would like. Obviously, that's up to the patient, and then discuss the risks along with that. If I were to consider an intervention in him, it would be a cervical epidural. He has now this advanced imaging, and so we know what's going on and where it is. And like Dr. Brooks mentioned, it does correspond with his symptoms, so I would offer him that. Personally, I would say you got to give this time. What was the timeline? How long had he had
It
it?
was about 6 weeks.
6 weeks.
For this one, yeah. So it's just at the end.
So yeah, he's quite young in his presentation, right? And if this is not truly debilitating, I would probably put the brakes on or not push forward with any intervention at this time. Again, it's kind of up to the patient. If he comes to me with a lot of momentum saying, no, this needs to be intervened upon. My dad's a doctor. He said I should get injected. I'm going to be influenced by that a little bit because it's his preference. And I'm just going to make sure that he's educated going forward saying, yeah, this is a safe thing. You're a relatively young person though. So if we give this another 6 weeks and you do the appropriate PT, you have a chance of resolving 80 to 100% on your own. And you know, that disc may desiccate, dry down. His symptoms may improve whether the disc stays that size or not. So the question or the answer to the question is, what would the intervention be? What would I do? I would probably do, if I were pressed and the indications are right, probably a C7T1 interlaminar epidural steroid injection with like a right paramedian approach. Going higher than that, especially into the laminar space, you just get increased risks. And it's shown that the medication spreads depending on if you get to the right spot, 2 levels up and 2 levels down. So that's my long-winded answer there.
Yeah. No, that's great. That's great. So a couple of follow-up questions, I guess. So one is, what do you think about transfemoral injections from your practice perspective?
I think for me, this is like a very anecdotal, but also a personal question. Like the trainers and attendings that I worked with at my pain institution didn't do a lot of transfemoral. So I never really got trained in it, comfortable with it, and happy with them. I tend to get a lot of good relief from interlaminars, but if it's something that I feel like is really indicated, it's single-sided, it's single level, it's shown to correspond with their symptoms, I'll happily refer to one of my colleagues and say, hey, do you mind doing this right-sided C6 or C7 TFESI?
Yeah. And then the next question I have is probably more kind of conjecture, possibly. Are there any new medications that might come on the market that would change the landscape for injections and longevity of treatment?
The only one I can think of that comes to mind is something like Jernavix, which is I don't even know the real name, but it's sugetrine or something. It's a different type of pain medication. I've only prescribed it a few times. It works at a different spot on the pain pathway than does an opioid or a gabapentinoid. It is not approved by the FDA for administration beyond 2 weeks. So it's kind of outside the scope of a lot of the chronic pain practice and practice providers that we work with. Michelle, have you ever prescribed Jernavix yet? Has anybody here? Yeah, okay. Nice.
Because the patient eats CRNA.
Yeah.
Like specifically asked you for it?
It's going to impact you or affect you
he asked me, hey, can you prescribe this for me? People are
You
asking.
had to look it up and do your research, right? Yeah. Yeah. I mean, as someone who prescribes pain medication frequently, I did with hesitation and trepidation because I'm like, I don't know, this is a young medication. And in any case, not beyond 2 weeks. I have used it a couple times since then in the indications of acute on chronic pain with flare after sometimes an injection that I've done in an RFA. So there certainly is a possible seat for it in the future with prescribing medications. In him, though, there's a lot of other things to try. I wouldn't hold that to my own and not give him Journavex if he tried some of the other things, but yeah, maybe in the future.
Yeah, so I think that's, it's always important to kind of think about the idea that perhaps someday either an oral or an injection would treat this partially inflammatory process, and the patients would be improved by that. So important to think about.
I actually did just want to mention sometimes Medrol dose pack jumps to the front of the line here, probably from you guys too. It's just a 5-day taper of a prednisone or a steroid, and it can have some pretty good effect in cases like this. Sometimes they have to be a little bit more severe in their presentation, a little more debilitated, but that's high up there with gabapentinoids and NSAIDs when it comes to those initial presentations.
Yeah, no, I think that's a really good point, in that for the medical students, especially if they're rotating in the ER and stuff like that. These are like the acute phase, really uncomfortable patients where the NSAIDs aren't cutting it. The other things that are not necessarily narcotics. Narcotics can be useful in short terms, but if they become a long-term thing in this, at least this is what I see. Of course, I see end-stage people, is that it becomes more of a centralized process, and the narcotics have not helped the problem. And centralized means, in my mind, they become addicted through a pain pathway. I don't know if you think of it that way too, but that's kind of how I think of it. Jim, what do you think about this? Now we've tried the slightly more conservative approach, and it's not working. Yeah. What do you think?
Particularly in the young patient, I do like to give things at least 3 months from a natural history perspective. Even the super debilitated ones, I'll tell them, have a Medrol dose pack, sleep this off, because particularly when you're talking about doing an anterior cervical surgery, I'm putting something in there, and I would like to not put something, even if it is a disc replacement, in somebody in their 20s if we don't absolutely have to. So,
yeah.
And the weakness doesn't really even scare me much, particularly in the cervical spine. I have always comes to mind this bodybuilder that I treated. He could bench 405. He came to me when he could bench less than 220.
That's right.
He had a C7.
It's all relative.
Yeah, and he was scared. And I watched him through it, and he can now bench 405 again, just fine. He never had surgery.
Right.
But say that this was chronically debilitating. This is, in the 20s age group, 30s age group. I very, very rarely would I do a fusion unless it was for some sort of, also they've got a congenital, they've got a clip file, they've got something. In this setting, it would be very well treated by cervical discectomy and arthroplasty. It's not. It's lateral. It's very gettable from the front. This would be a wonderful operation for that.
Yep. Good. Okay, Brad, posterior option.
Yeah, I agree with everything Dr. Berdan said and Dr. Pride, and that obviously, yeah, in a young healthy person, you're gonna drag your feet as long as possible on this, right? Because odds are they're gonna get better without any real intervention. But we're forced to go from behind. Something like this. This is where I try to think as minimally invasive as possible, right? We don't want to do as little as possible for this person to try to get relief. That's where something, whether either it's probably through a metrics tube or an endoscopic, might be a great option here, where you're looking more at a foraminotomy. Now, initial disadvantage to the foraminotomy is it's an indirect decompression, right? You're really not attacking the problem, which is the disc, right? The foraminotomy, you're unroofing around the nerve and everything and making giving room for the nerve to float away from the disc, but the disc stays. That being said, endoscopic, a lot of times you're able to get in the axilla of the nerve root and can get discectomy as well. This is slightly more medial than I'd hope, but you might be surprised if you did an endoscopic foraminotomy that you might be able to get that in the axilla and get that disc out. But even if you couldn't, worst case, you indirectly decompress by making room around the nerve, and then you could get in and out and not destabilize, and incisions, centimeter and a half, and that's it, and send them on their way.
Yeah. So, yes, sir.
Follow-up question there. Why do you think you're better at doing a discectomy with an endoscope than with a metrics tube? What's the difference?
Yeah, so the endoscope has like a 30-degree angle on it, so you can actually more easily visualize underneath the nerve root and the dura safely. Whereas the metrics tube, you're confined to a very rigid straight down tube. Yes, you have the advantage of the metrics is you have all the tools that you're normally used to using, right? Your normal curettes, your normal drill, your normal bipolar suction, all that, right? The endoscope, it's all these different tools and things like that typically, but that the angulation of the camera really lets you kind of get in there and a little bit safer, and it's that much smaller to sort of sneak around the edge of the dura.
And the irrigation has a huge effect. It actually, unlike what you often see when you're doing a tubular approach, posterior approach, the dura is kind of up against all the bone. With the endoscope, there's just enough space where you can see a nice axilla. You can see, and then there's the bleeding is really taken care of and all that kind of stuff. The stuff that's kind of normally sitting in the base where you're trying to see in a foraminotomy. So that's one issue, and then the other is the tools just are smaller and very easily controlled because you're right down in there. And so that it's been an interesting phenomenon in my practice, because when I first started doing surgery, we didn't have the endoscopes, and I would do tubular discectomies all the time. And all I had ever do really was just the foraminotomy, because I couldn't really see well enough to be comfortable. And then once we got to the point where we started doing endoscopic cases, that's when I was like, oh, there's like a big disc there, just like in the lumbar spine, and you're like, oh, and you just pull it out, and you'd be like, oh my God, this is great, right? But of course, on top of that, you have to realize that you actually have to be very careful now suddenly, because normally you're not, in the posterior approach, you're not near the vert. But if you start reaching in the disc space, you are again near the vert. So you have to be cautious again about what the anatomy is that you're working around, and things that you can do with the endoscope. So so I think this is great for this case. The number one treatment option described by everyone was a little bit more time than a few weeks. And I think that's important. I think that from the physician perspective, one of the things that we say in surgery, which is pretty easy for us to say, is like, we only get paid to do surgery. So if we're trying to talk you out of it, you should listen to us. And so they sometimes they believe that, and generally they do. And so I think that's really helpful, and that the natural history of this is it can be benign. But if the patient's body decides that the conservative, quote unquote, non-surgical treatments are not working, then surgery certainly is an option. And I think either one of those is fine. I mean, that's the thing the frustration that you get when you're learning about all this is that you could do either, and nobody's gonna argue with that. So. All right, we'll do one more case just because we want to get back on time again. This one's a 50-year-old with cervical stenosis and radiculopathy. You can see multi-level radiculopathy, and let's say the radix on the left side. And multiple dermatomal distributions, but clinical examination does not have myelopathy. So we'll start with Kath.
I think this is a little bit more in line with what typically crosses my desk and office hours. I don't know the last time I saw a 25-year-old with radiculopathy. I don't know the last time I saw a radiculopathy that was only 6 weeks old. So this is certainly a little bit more commonly what I see. It doesn't, so no previous surgeries.
No prior surgeries, just kind of been having a little bit more neck and arm pain, and worse with extension, so that really has got kind of like a positive Sperling sign. And we'd say the most notable levels are C6 and C7 on their clinical examination.
Okay.
Still reasonably functional.
Right.
So,
okay. Functional, but debilitated or angry enough to come to see me and wait the X number of months to see me. So he's certainly unhappy with some of his symptoms, whether it's pain or it's his debilitation. And so he'd be treated like anybody, more conservative first and then moving on. So depending on what he would prefer, the medication management options would be available to him to include gabapentinoids, gabapentin, then Lyrica, possibly duloxetine.
Can I ask you about that? So gabapentin, more recently by the FDA, has gotten a lot more like scrutinized. What do you think is leading to all that?
I'm not certain if it's not necessarily an easily abusable drug. I have not seen, I don't think almost any patients really abuse it or try to use it to the tune where it's not necessarily prescribed as. Most people, it's actually quite polarizing, meaning you either really like it and what it does for you, or this is not for you because it almost killed your mom and your sister had these hallucinations on it. So personally, I use it actually. I use it every day, but you know, I'm not paid for that, and I'm just a customer. But I do know that it does positively affect a lot of different people with neuropathic pain, and radiculopathy is high up on that list. And if you can tolerate the side effects, it is certainly a good option to consider. And there's not a lot of, I mean, as long as you avoid the higher doses, you can really get away with some good therapy from it without a lot of side effect. I don't want to concentrate too much on it. They may have a lot of other additional symptoms. Muscle relaxants would certainly be considered if they haven't tried any NSAIDs and Tylenol, all that. Oftentimes, these patients come with associated pains like trigger points and myofascial pain. So certainly that's something that I would offer them if I found that on my physical exam. Depending on how debilitated, again, they are, a cervical or a surgical evaluation or referral is certainly warranted and something I would consider. Again, it would be the same type of injection option. I only have so many. So it again would be an interlaminar C7 or T1. And then if again I thought it was one-sided, consider sending for a transforaminal. But I don't know where I stand on EMG on these cases. I don't know if it necessarily changes a lot of my practice and what I would do personally. I think you guys may use it a little bit more in these cases. I'm not certain. But I think as long as we considered all the conservative managements first and then possibly epidural steroid injection, and he's got to meet a few more wickets before any more invasive or interventional procedures from me. So.
Well, I think you bring up a valuable point from a diagnostic perspective. You know, the EMG is really not going to change management if you're confident it's a cervical radiculopathy. But if you got to go, yeah. But if you are not clear, say you think maybe they have a peripheral neuropathy or brachioplexiopathy, you know, Parsonage-Turner, ulnar neuropathy, median neuropathy, all these things kind of can happen. And Parsonage-Turner, which is brachioplexiopathy, happens with so much frequency, it's kind of hard to believe. I mean, we see it regularly in the ED and stuff like that. And so trying to sort those pieces out with an EMG if it's not totally clear is a good idea. And then the other part, of course, is if they have peripheral neuropathy or shoulder problem or some other thing going on, if you're treating their neck, which is probably the most dangerous spot you can be treating, and that's not actually going to help them, that's probably not doing them much of a service. So you want to be careful, very careful about that. So that's kind of the thought process regarding EMGs. I don't usually make people wait for EMGs if I'm pretty confident in what's going on, because it does take a while to get them, but certainly is a diagnostic test that can be helpful in some patients. Jim, what do you think? So we're going to move to the patient now probably needs surgery.
Yeah.
And what are we going to do? Anterior.
And you said they have a 6 and a 7.
6 and a 7
radiculopathy.
radic, yeah.
Okay. So
And you don't have to do an anterior. I won't force you to do it.
Okay.
But you can,
just looking at the imaging, the 4-5 level looks a little tight as well. That axial isn't quite as bad.
Yep.
So let's say they don't have C5 symptoms that I think this is isolated to 2-level disease, and we want to do a surgery on it. Kind of broad-based disc osteophyte complexes. You can tell without an X-ray that there's some bone spurs anteriorly. This is a pretty degenerative neck. I think I'd prefer in this case an anterior surgery, and I'm going to go with a fusion rather than an arthroplasty. I don't see his facets, but I assume they're pretty arthritic as well. So I don't think he's a great candidate for an arthroplasty. So
yeah, I would agree. Not an arthroplasty candidate.
Yeah. So if I were to treat this, I would go with a 5-6, 6-7, so a 2-level anterior cervical discectomy and fusion.
So this is where that we get into that judgment issue of, and and the discussion with the patient, right? We've got 5, 6, and 6, 7. We're going to do a fusion. What do you say to them about adjacent segment degeneration and their chances of coming back to see you?
Yeah, I would highlight to them that their 4-5 level doesn't look great to begin with. And so this is, everybody's got an uncle who had 5 back surgeries and every one of them was worse than the last one. And so I kind of explained to them that that's where this comes from. So I would say that there is a non-zero chance that they develop adjacent segment disease above or below. I generally quote the 1% per year type of numbers of needing another surgery. But I don't think it would push my indications in a different direction where
you wouldn't necessarily do a fusion at 4 or 5 just because that's a chance.
Correct.
There's a chance going on there.
Yeah.
So I think that's important. I think it's important to have the discussion with the patient and try to explain to them, that you're fixing their body as it's wearing out, essentially. And so you're trying to fix what their problem is now, have a reasonable discussion about what potential problems they might see in the future, because I think that's an issue. Any other questions? I know I'm kind of leading the charge here, but. All right. Thanks. No, I appreciate that. Okay. And yeah, I agree. Arthroplasty would be a hard sell unless you were in San Diego, then you could do 3.
Yes.
Yeah, with cash. Okay. All right. Brad.
Posterior. Yeah, a lot to consider here posteriorly. One, Dr. Brooks mentioned that there's no concern for myelopathy. But you have to remember, neurosurgical guidelines say that radiculopathy could be actually along the spectrum of myelopathy. So this could actually be the first sign, for instance, of the patient's myelopathy, just as a perspective, right? So I think you always have to consider that central stenosis along with the radicular pain. And so as you look at that, a lot of different options. If you were just focused on the radiculopathy, could you do a multi-level MIS foraminotomy like we just talked about last case through a tube endoscope? Absolutely. I've done that. I've done multiple levels. You can get 2 levels in one tubular incision. You just kind of angle, realign the tube, and you're fine. 3 levels a little bit tougher, but you can always extend your incision a little bit. But okay, what if you are worried about that central stenosis, which I kind of am, honestly, right? Then you have a lot to consider, right? We talked about laminectomy. Well, he's 50, so you're worried about long-term instability risk. Although their lordosis looks actually pretty darn good, as a 50-year-old who's probably relatively active, younger, has a lot of years left to live, I'd be really worried about long-term instability problems. So I probably would not do a laminectomy. So then laminoplasty, right? That's that nice middle ground we talked about. And then we mentioned that most systems are on the left side. So if you do your laminoplasty, right, open your door on that left side. When you're there, you can do foraminotomies at those levels on that left side as you're doing your laminoplasty before you put the plates on. Last option from that regard is a laminectomy infusion, right? Lots to consider here and unpack, right? So obviously alignment looks good, no spondy, no subluxation, good lordosis. Granted, I don't have the x-ray, but assuming the lordosis looks great, nothing crazy. Okay, I would not advocate probably for fusion myself, but then you also have to consider 50-year-old again, right? Long time to have future problems too. So I could at least see the argument for someone who wanted to do a laminectomy infusion, albeit again, I would not do that. I think in my hands, I would be concerned about the central stenosis. I would be concerned about, 50-year-old want to preserve motion. I think the laminoplasty, open door on the left, do your foraminotomies there, I think is probably how I would lean personally. But that's the beauty of spine surgery. None of those are right or wrong answers, I don't think, except for maybe the arthroplasty.
I don't know everybody thinks that's a beauty, but that is what spine surgery is like. Yeah. I think that there's a lot of different ways to deal with it. And what I'm going to ask you this: what do you think about minimally invasive laminectomies for this and foraminotomy?
Yeah, I mean, you could. One of the cases I showed in my talk. Again, I've done a 2-level. I've done 3 or 4-level lumbar lamies, all MIS through multiple tubes, I've done a 2-level cervical. I've never done a 3, but it absolutely could be done. It could be done. You just have to be more careful in cervical, right? In the lumbar, you have a lot more flexibility, right? As you're reaching across the midline, right, you can depress the direct because it's nerve roots, right? Here, you don't have that flexibility. You cannot depress on the cord. So as anything you do through that tube, whether if it's across the line, you'd be very cognizant of that, right? You approach that. You can do it because I do it and they do fine. But you have to be very cautious and very aware that it's sort of a different MIS laminectomy than it is in the lumbar spine, where you have a lot more flexibility to depress the nerve root, get out the contralateral side, right? You can't do that here, right?
Yeah, I think the nice thing is that there's less tissue to remove. The not so nice thing is that there's less tissue to protect you from the spinal cord. So you have to be very cautious about that. And I think Jim made a comment earlier about posterior approaches, and endoscopy has really changed that
which is that we're worried about pain and you're worried about infection. Both of those things are a lot more limited with endoscopic approaches. That's the positive side for us and the patients. The downside is, of course, you don't get paid as much as if you do an ACDF or an arthroplasty. So there's this kind of perverse incentive thing going on which direction those things are going to go as well. So I think when we think about this kind of more conventional options that you guys talked about, I think those are still the options that most people are going to take. And then potentially in the future, there'll be other options depending on the degree of numbers of stenosis. The most I've done is 2 endoscopic approaches, which doesn't take that much longer because the cervical spine is just a little bit easier than the lumbar spine. But certainly these things could change over time. So I want to thank you guys for giving us great talk and really taking your time out of your day. I really appreciate that. We all really appreciate that. So thank you very much. Thanks, Jim. Appreciate it. Yeah. All right, we're going to move forward on our next. Thank goodness we build in buffers, right? So we can try and keep ourselves. Thank you very much. So our next topic is going to be rheumatologic disease, and my first person to introduce is Dr. Christy Bartels, who's a rheumatologist, a medical doctor here amongst the surgeons. Yeah, and we're going to make sure you get you mic'd up. So let's get that going. But of course, the reason I wanted to talk about this was that historically, before there were good medications to treat some of these rheumatologic diseases, surgeons were heavily involved. So if I don't know where Tribute is now, but if Trost were here, he'd tell you all about all the transorals he used to do because it was just so common to have compression on the spinal cord from rheumatoid pannus, and that was a huge problem. And now it's pretty rare. In fact, I was very much hunting for cases when I was looking for cases for this afternoon. And so I think this is important to know. It's important to understand what meds are there, what are the side effects, what are the pros, cons, and diagnosis, because I think the other part is that we'll see patients that the first point of contact for them in the healthcare system is the surgeon because they have compression on their spinal cord. And we want to make sure that we're not actually doing surgery when we should be doing medical care. So, Christy, thank you very much. Appreciate it.
Those are fabulous points. We see patients that have really had a carpal tunnel release, who've had
Make sure you're turned on. Yeah.
had other surgical procedures, years before they made their RA diagnosis, which obviously was the pivotal point. So I love the intro there. Again, I'm chief of rheumatology here at UW, and rheumatologists dig medicine. So call us if you've got questions. About 5% of back pain is inflammatory back pain. Best question is morning stiffness, right? My classic, I had a woman who was a custodian. She told me she was afraid to not go to work because her back pain was always worse if she didn't work, right? That's a weird story, and that's inflammatory back pain. All right, so with that, we're going to talk a little bit about some common rheumatologic disorders, and we'll talk a little bit about medical treatment that I think is relevant and in the wheelhouse of surgeons to know, including a few perioperative pearls. So the first case is a 60-year-old who's got deforming hand arthritis, has had long-standing hand arthritis, and presents with occipital headache. And what I'm pointing out here is this atlanto-dens interval that's almost 10 millimeters. Anyone from the audience want to holler out what we think is happening to this lady? Anyone?
Any history of trauma?
No history of trauma.
Okay. Yeah, I would assume, given her history, probably some kind of pannus formation.
Yeah, so she's got rheumatoid arthritis, so she has a differential diagnosis, which would include pannus formation or just atlantoaxial instability, where she's got flexion extension views here, where you can see actually that interval on the left looks pretty normal, and on the right looks increased. And so maybe just atlantoaxial instability. So I love it, but rheumatoid arthritis is exactly what she's got. So again, thinking about who gets rheumatoid arthritis, more common in women than men, 3 to 1, often presents in 3rd to 5th decade, though obviously some people get it in pediatric cases and continue to be positive, and most destructive in people who are seropositive, which includes both rheumatoid factor or CCP, which is that acetylated protein, which is associated with this HLA-DRB1, which is a familial risk Folks who have familial risk and are smokers are 36 times more likely to get rheumatoid arthritis. So again, just thinking about kind of the phenotype of who you might expect. The hand you see there is the old hand, like we're saying, that we saw a lot more commonly before we had great meds. We have great meds now. We can often get people in good durable remissions, and we don't see a ton of these deformed hands anymore. But again, you'll sometimes see people who've had disease for 2 and 3 decades, and so they got it before they had good treatment, so it's useful to know. On the right, it's just showing you a macro of what's happening in the synovium. So in synovial-lined small joints, essentially you're getting inflammatory cell infiltrates, you're getting an expansion of the synovial membrane, you're getting increased vascular formation, and eventually all those inflammatory cells bring in matrix metalloproteinases, which actually cause those marginal erosions, right? So where we're seeing here at the corner, on the bottom corner, you can see that synovium is actually causing the erosion of the bone. And so really the treatments are aimed at trying to stop that cascade of cellular infiltration and increase cytokines to stop the bony erosion. Great differential diagnosis from our audience here. Again, one of the things to know is that C1-2 is synovial lined. And so essentially we can get this increased distance. We see this example on B on the left here, where normal is about 3 millimeters, and here we've got cord danger if we've got slippage of more than 8 millimeters. And what happens is we can get erosions on that axis. We can get, so it gets thinned and narrowed and then basically gets slippage. We can get ligamentous laxity. But essentially what happens in folks who've had long-standing RA or poorly controlled RA is we can get instability of that C1-2. Probably remember this from med school, that they basically point out that either you need flexion extension views before you intubate this patient, or you need to use a fiber optic scope. And so again, you can get MRI and you can see a lot of the details on this. On the right-hand side of the slide here for you all, the differential being rheumatoid pannus is also out here too. And so again, the inflammatory cells can make these whorls. It's also similar to the pathology you've seen of rheumatoid nodule. And essentially, that can cause a physical barrier that, again, in the lower right schematic, you can see can cause actually myelopathy here. So a couple different ways that RA can cause neck pain and pathology. This slide is just to tell you that there's a lot of different medications, and there's a couple of good take-home points, and they're on the left. The first is methotrexate is safe enough that in a low-risk procedure, you can continue it through surgery. You don't have to hold it. 8 out of 10 studies have shown no increased risk for infection, and in fact, it'll spare you the steroids that would probably harm newborn formation and setting of your procedure. But we do know that the biologics, everything on that right-hand side, should be held at least 1 cycle. And on here, I've got the dosing, so you can see the dose intervals on those, which can be up to, monthly. So planning ahead, if you have the option, will decrease your odds of postoperative infection 5-fold. Okay, so plan ahead on that. And just a general rule of thumb, I often tell people hold about 2 weeks before and 2 weeks after if you've got the luxury of time, right? If it's non-traumatic. This is just showing you that the top is a bunch of anti-TNF inhibitors. All the UMABs mean it's a humanized monoclonal antibody. So if you hear a UMAB, that's a TNF, or generally a humanized monoclonal antibody. And on the bottom, you see that the tofacitinib, baricitinib, and upadacitinib, those are small molecules, which some people don't consider biologics. But if you group them with the biologics, the risks are the same. Increased risk for infection, including fungal and other atypical. So really think about that. Couple other things on this far right. Again, you could print this later, and I'm not going to bore you with all the details, but one of the things to know is that if you already had MS or a demyelinating disease, the TNFs are going to make that worse. So know that, and that's worth knowing. And then down at the bottom, it's just also worthwhile to know that rituximab, even though we use it to treat sometimes myelopathy, inflammatory myelopathies, can also cause reactivation of PML. So just kind of be aware of the differential that might be in the wheelhouse. All right, so those are kind of the big pictures on treatments. I've got another audience participation here. This is a New England Journal picture, but a case scenario I saw again myself on clinic or in the hospital, an 88-year-old who had 2 months of neck pain, high inflammatory markers, and she presented with some fever. But the imaging showed a different differential than I think the ER initial exam had. What do you guys think? Anybody see that where the arrows are there and want to hazard a guess? Go ahead. So it has to do with the ligament. Anyone else want to hazard a guess? What's happening there? It's calcified, right? So anyone want to hazard? This is kind of a cool one. So she's got calcium pyrophosphate disease. And so it turns out that about half of people get, and this used to be called pseudogout, right? So calcium pyrophosphate is calcification of any, it can be in cartilage, it can be in ligaments. And essentially here you can see that tiny little ring. And essentially she's got also on the far right, you can see if we look at other radiographs, often they've got evidence of chondrocalcinosis at other sites, the wrist, the knee, the pubis symphysis, other calcifications. And interestingly here, when it's at the C1-2 level, it causes terrible headaches. It can present as FUO, and it's called Crown-Dens syndrome. That's like, there's even an eponym because it's so common. So it's worth knowing this. So CPPD is super common. 50% of 80-year-olds have some sort of chondrocalcinosis, but this presentation is relatively rare, but obviously not a surgical indication. So super helpful to have this on your differential. And the imaging can make the diagnosis. So CT spine, DEXT gets you really nice crystal images. SED rate and CRP can be high. You know, obviously it can mimic meningitis. If you got that case and it was acute with a fever and neck pain, you might even think about an LP, but in this case, we could spare her that. We got her on some steroids for about 14 days, and she actually defervesced. So helpful to know this in your differential. This is my final case, and I've got a 56-year-old. This, again, is a patient I actually take care of. He had had ankylosing spondylitis for 20 years. He slipped, he fell on the ice, reported mid to low back pain. He was bound down, and he called my nurse in clinic and said, "What do I do?" And on the right, and first of all, on the left, we've got a classic, what would we call this, spine and ankylosing spondylitis when it looks like this. Bamboo spine. We got a beautiful bamboo spine. On the right, we've got a less beautiful bamboo spine. What's happened here?
Right.
Anybody?
Looks like you have probably fracture osteophyte complex.
Exactly. He fractured that osteophyte. So my nurse was an old ICU nurse and was smart and said, "I'm sending the squad, stay down," and probably saved this guy's ability to walk. So good case here. So ankylosing spondylitis, they make flowing osteophytes, they make bamboo spine, they make bone. Psoriatic, IBD associated arthritis and reactive arthritis also can do this. And again, this is a problem of bone formation rather than bone destruction. So the biologics here are trying to block that new bone formation. So again, hopefully newer treated patients are going to be less likely to have this, but good to know the pathology. So quick summary here. We treat aggressively, and we want to monitor that C-spine and RA. We want to remember that CPPD and Crown-Dens is on the differential for older adults. We want to make sure we kind of presume that a spondyloarthritic spine is fragile. We want to hold biologics for 2 cycles or 2 weeks pre-post, and then call your friendly rheumatologist anytime you've got questions. All right, and with that, pass it on. Thank you.
Much. I'm truly impressed because I know exactly you have way more things you could be talking about in regards to this. So that's very good. You're welcome to sit up there and just come back in a little bit. Yeah.
Thanks.
Thank you very much. Okay, so we have Dr. Poliak-Tunis coming to give us thoughts about the kind of non-surgical treatments of rheumatologic and spondyloarthropathic pain. And hopefully we can learn a little bit more here as well. So thank you. Thanks again for.
Yeah, of course. Can you guys hear me? Oh, great. Well, I will say that this topic is interesting because, and Kath left, but we in the interventional pain world don't see as much, especially cervical rheumatological stuff. So a lot of things that you were going to be talking about later, I'm just going to tap out and go, Dr. Bartels, I don't have much. But thanks for having me today. So we're going to talk a little bit about rheumatologic disease process and really interventional pain management. I have no disclosures. So to define the burden of inflammatory arthropathies on the spine, summarize some high-level evidence for interventional treatments, clarify what interventions can and cannot accomplish, because that's also very important, and discuss the safety, patient selection, and surgical referral thresholds. So rheumatoid arthritis, there's 0.5 to 1% prevalence. Cervical involvement is up to 80% over the disease course. We have axial spondyloarthritis prevalence anywhere from 0.3 to 1.4%, and this is where you really see more in the SI joint and spine with primary sites. Psoriatic arthritis, axial involvement anywhere from 20 to 40%, and really our surgical colleagues see these patients usually later with when they have structural disease, but their pain is happening before a lot of that happens. So we do see some of these patients. So why does this matter to our surgical colleagues? Like I said before, pain often precedes deformity or neurologic deficits by years. Inflammatory and mechanical pain generators frequently can coexist. And some of the interventions we do can reduce pain and improve function while systemic therapy is optimized. And again, systemic therapy is optimized. You just heard from Dr. Bartels how important and how many different medications now exist. And I'll say that's probably why we actually don't see as many of these patients anymore. Most importantly, procedures do not modify disease or prevent instability and ankylosis. So again, we can help hopefully their pain and their function and their quality of life, but at the end of the day, structurally, we are not changing what's happening. So with rheumatoid arthritis, and again, you'll see a lot of the same pictures because especially with cervical spine, we talk about the C1-2 potential instability. So you'll have synovitis that can lead to ligamentous laxity and erosions, and then eventually to instability. And then with the axial spondyloarthritis, you have enthesitis, erosions, and pathologic new bone formation, and then the ankylosis and fracture risks. So what can we do for these patients? So DMARDs, as were just discussed a few moments ago, and biologics are first line for these patients. So most of the time, if they come to the pain clinic, if they haven't seen a rheumatologist and I get x-rays and they have a bamboo spine, the first thing I usually do is say, I think you need to go see rheumatology. And they'll say, well, why? And we have this back and forth, and really because they should probably be on a biologic, most likely. Exercise and rehab are strongly recommended as adjuvant therapy. Can we do interventional procedures? Sure, for symptomatic, and again, this is adjuvant therapies. If there's specific targets that we can target, then we can, and then if not, then our surgical colleagues for instability, deformity, fracture, or any neurologic compromise. Exercise in rehab. So Cochrane review, exercise improves pain and function in rheumatoid arthritis patients as well as spondyloarthritis patients with a small, moderate effect sizes. And then there's strong recommendations for exercise in inflammatory arthritis. So this is a picture that I literally Googled. And I found for physiotherapy, daily exercise to help with inflammatory arthritis. So patients can find these exercises online just by Googling. So they don't have to go see physical therapy. So these do exist. What about injections? So I said I'm a PM&R physician, but I primarily do interventional pain management. So lots of different things that we can do, but as you heard from Dr. Pride earlier from Keth, doesn't necessarily mean we do these things. It just means that we could potentially do these things. So we could do epidural steroid injections, we can do facet joint injections, medial branch blocks, radiofrequency ablations, SI joint injections. We do a lot of trigger point injections, but again, it depends on what the pathology is and why the patients are coming to see us as to whether or not any of these procedures make any sense. So what are some of the evidence? So in the general population, so for radicular pain, hopefully if it follows some sort of dermatomal pattern, there's moderate evidence for short, intermediate term benefit for ESIs. And then, which is kind of the top picture just showing dermatomal pattern. And then with medial branch blocks and radiofrequency ablation, there's moderate evidence for selective mechanical facet-mediated pain. And that's on the bottom right is a referral pattern of where if we think the pain is coming from the facet joints, where their pain may refer to given the pathology. With SI joint injections in axial spondyloarthritis, small RCTs, and there are some small cohort studies, there is short-term benefit from it and pain and function improvements versus baseline and placebo. But as I mentioned before, there is absolutely no evidence of disease modification or long-term structural benefit. So again, you'll hear me say this a lot, it should be in conjunction with, right? Not freestanding alone, the only thing we're gonna do for these patients, but really to facilitate rehab and function while systemic therapy is being optimized. Rheumatoid arthritis in the cervical spine. So as I mentioned before, the cervical involvement is up to 80% over the disease course with atlantoaxial subluxation is common. And natural history studies do show progression to myelopathy in a subset if these patients are not treated. Our injections can help pain, but do not prevent neurologic deterioration. So later, it's interesting when I think about what procedures I do, and like C1-2 injections, I've never performed a C1-2 injection because it's very uncommon that we're asked to do those. And I think it's because rheumatology has done such a great job with their medications that we don't see it as often. So what are the ideal candidates for interventions? Pain is consistent with neuroanatomical distribution. They have failed conservative management, so whether that be physical therapy, medications, acupuncture, et cetera. Absence of significant psychopathology. I'm sure everyone in this room would agree with that. Lower disease burden, so hopefully not on high-dose opiates. If we're talking about, are you a candidate for radiofrequency ablation? Did you have positive diagnostic blocks? You have to for us to proceed with that. And some contraindications, if you have an active infection, we should not be injecting you. Coagulopathy. If you have an inflammatory arthropathy with instability, really, we should be sending you to our surgical colleagues. And if you have severe central sensitization pain syndrome, injections most likely are not going to work for you. So we should be having a longer conversation of what's the best option. So what can interventions do and what can they not do? So they can reduce focal nociceptive or radicular pain, improve short-term function, and really facilitate rehab. They cannot control systemic inflammation, prevent instability, or stop ankylosis. So again, I'm a broken record, but really it should be part of a multidisciplinary stepwise strategy when we talk about injections. And when do we refer to our surgical colleagues? So progressive neurologic deficit or myelopathy. If there's instability, especially with subluxation, rheumatoid arthritis, severe deformity, fracture, or mechanical failure, or if a patient has intractable pain with clear structural pathology despite optimization of all these other modalities. So what are some things that we need to look at? So people like to talk about regenerative medicine, kind of like what you guys were talking about in San Diego, that you can get like 5-level, disc replacements. Depending on where you are, you can also do a lot of high-tech regenerative medicine, but there's not great studies on that right now. So that's something that we should be looking at. Standardization of techniques and patient selection. Also, we don't have great studies on that. Long-term outcome studies. Are any of these things cost-effective? And which patients benefit most from these procedures? Some emerging technologies we're using. So most of our procedures we do are under fluoroscopic guidance, but ultrasound is becoming more and more useful. So we're using more of that. Biologics such as PRP and stem cells, some in the community are using that, but some things to look into, and then combination therapies as well. So systemic inflammatory diseases, and this is where systemic therapy has the largest effect sizes. Interventional procedures provide modest short-term adjuvant benefit in selected patients, and really risk profile infection and fracture instability is higher than in the degenerative disease patients, and really close collaboration between spine surgery, pain, and rheumatology is really critical for these patients. And these are my sources. Good.
Thank you very much. Yeah, so I think one of the things that both the interventional pain and surgeons will want to just keep in mind here is that we always want to make sure that we identify somebody who might have not had untreated rheumatoid or untreated rheumatologic disease, because I think that's the key. It used to be that we were kind of the primary folks helping with some of the effects of rheumatoid arthritis, and now it's more like we want to make sure they get their medical treatment. So thank you, Michelle. Appreciate that. Next speaker is Dr. Zazu, who's a new faculty with us, is coming via Indiana and then St. Louis, and did a combined orthopedics, well, actually an orthopedics only fellowship, right? Yeah. He's a neurosurgeon, but he just wanted to see what the bones were like. And so he's going to talk to us about the surgical management of rheumatoid disease, which of course is one of our more fun surgeries to do, but don't do it as often anymore. So thank you.
All right. Thank you for having me, Tan. So I have no disclosures. As you heard today, rheumatoid arthritis targets synovial joints, ligaments of the spine. It can cause instability or neural compression, which we will get into. It can affect in the cervical. I'll focus mainly on the cervical spine. It can affect the upper cervical spine. The atlantoaxial dislocation or instability that we saw pictures of, we will see more of that. Cranial settling or retroodontoid penises. Lower down, as you go down below C2, then you get the, sorry, in the AAD first, I'll talk about its most common spinal abnormality in the rheumatoid arthritis. It affects about 25% of the patients. And it is primarily because of the disruption of the transverse ligament. This is a picture that we saw one before. And you can see that when they are flexing, if you imagine this transverse ligament in there, it holds the odontoid process just behind the anterior arch of the C1. So if the patient is flexing forward and this ligament is not there, then you can see that distance is increasing. The cranial settling, in here you actually see both the cranial settling and you can also see increased in the ADI. It's because of erosions in the occipital condyles and the C1-2 joints. Basically, the skull just settles down on the cervical spine. It can be life-threatening if this bony prominence is indenting into the brainstem. The retroodontoid pannus is a proliferation of the fibrovascular tissue in there. You can see it compressing the spinal cord over there. And if you stabilize the spine there, there is many case reports and studies that it can regress. Lower in the cervical spine, the subaxial subluxation is very common in the rheumatoid arthritis patients. We can get even a multi-level disease like you see in here, which is sometimes called a stepladder deformity. This is another picture of that, and you can see it's moving a little bit, especially here at 4-5. And this MRI shows clearly that stepladder deformity in there and how this can contribute to compression of the spinal cord. It can still affect even lower down in the spine, like the lumbar spine. It is less common than the cervical spine per se, and it can cause all the different degenerative disorders that we see in the lumbar spine in general. What's more important than what actual surgery we do is the timing and the indication for the surgery, because you will see that it's really different type of screws, like very limited types of screws that we can do in there, very limited surgeries that we can do in there, but who would benefit from those surgeries? So neurological deficits is the biggest thing for us as spine surgeons. It would be any progressive course. So basically Ranawat 2 or 3A. Ranawat was a orthopedic surgeon. He was not a spine surgeon at HSS, and he came up with a few of those criteria. Or early decompression and stabilization is recommended if the patient is becoming bedridden, which is progressing towards the highest Ranawat of, and I will show you that system. Intractable pain, so if they go to our colleagues in PM&R and they are not getting better, then it's an indication for surgery, or obviously progressive deformity. This is the Ranawat classification for cervical myelopathy. 3B is basically someone who is not ambulatory anymore, so they are bedridden in there. And objective weakness starts at 3A. 1 is a normal person and 2 is subjective. There are radiological criteria for surgery as well. Usually we try to offer surgery when there are symptoms, but there are certain radiological criteria that if you see them, then there is an unstable spine in there. If we start with the posterior one in there, the posterior atlantodense interval, if you can imagine, this is where the spinal cord is. So the lower, the worse. So less than 13 millimeters would be an indication for surgery. The ADI is the one in the front. So this is where, if this gets bigger, the other one gets lower. So the higher, the worse. And if it's more than 9 millimeters, that's an indication for surgery. And you can see here in this picture, you can see both of them, one increases when the other decreases. Cranial settling is another one where Dr. Ranawat came up with an index in there. So the distance from the center of the C2 pedicle as you go up along the axis of that odontoid process, and you have an axis of the C1. If this distance decreases, then the skull is settling more and more down on the C-spine. And there is another index where you can measure it from McGregor's line, which is basically a line from the base of the skull to the heart palate. Surgical approaches, as I mentioned before, are very simple. Posterior or anterior. In the anterior, you do C1. In the posterior, you do C1-2 fusion or occiput to cervical fusion. Anterior is odontoidectomy. C1-2 is our standard surgery for atlantoaxial dislocation. There are many different techniques, different types of screws, McGurl, lateral mass screw, and C1. And then in C2, you put pars or pedicle screws, and also some pictures of those, or laminar screws if you have high riding verts and you don't have access to put a good long screw in there. So that's the typical C1-2 fusion. This is the pre-op MRI on the left and the post-op on the right, and you can see that pen is completely regressed in there just by fusion without decompression in the front. This is the transarticular screw where it's going down from C2 and traverses the joint between C1 and C2 and goes up into the C1 joint. This is the laminar screw if the verts are suboptimal for a placement of a pars or a pedicle screw. Occipitocervical fusion can be done, especially in cranial settling. This is very important, or even in AAD when there is posterior compression and you have to do a decompression in there. So you're removing more bony elements from the back, and this destabilizes the spine more. So you might need to extend. And in here, again, another patient where they got an OC fusion and the pre-op and the post-op MRI. In here, it was not a complete resolution, but you can clearly see it is much smaller. With the posterior removal of the C1 arch, you can tell that you created enough room around the spinal cord that you would not do the bigger surgery. So this is the bigger surgery. Odontoidectomy, as Dr. Brooks was mentioning, this is a surgery that we rarely do now. You can do it through different approaches, whether from the mouth, from the nose, or from the neck, and I'll show you the different corridors. It's a high morbidity surgery. Obviously, this is why we're trying to avoid doing it now. And it requires posterior stabilization. So posterior surgery can be enough on its own, but this surgery would require also posterior surgery. So if you imagine this is not a rheumatoid arthritis patient, but you can clearly see here this bony deformity and indentation into the spinal cord. If you go from the nose, that's the first corridor in there. If you go from the mouth, this is the second corridor, gives you a bigger corridor in there. Usually we do that. We used to do that with ENT. And then in the third one, if you do it from the neck, it's not really optimal because you can see here that the posterior aspect of the C2, you can't really get access to all of it unless you remove more and more of the more subaxial spine, and you don't want to do that. So that would be what it looks like in there. You go down in there and then you remove this mucosa. Here, the C1 anterior arch is already removed, and then you start drilling the C2 odontoid process. And this is what a CT looks like. On the right side is pre-op, and on the left is post-op, and you remove the compression from where it's originating. And that's it. Thank you.
Okay, so thanks. Could I get all the speakers up front? Pieces here. Great picture of Devil's Lake.
Yeah.
Of course, you know, put the cart before the horse, but so this patient's coming with neck pain, 45 years old, and what's going on, BJ?
Yeah, I mean, C1, C2 subluxation on the extension looks like there's an increased distance between C1, C2, I think.
So the patient is, you can see mobility of C1 on C2 on the imaging. Okay. What kind of clinical exam things are you going to look for?
Myelopathic signs, particularly that may be like intermittent, I would say, since their compression is dynamic.
Looking for like things like hyperreflexia,
Yeah, hyperreflexia,
gait ataxia, Hoffman's, those kinds of things, because you want to figure out if the spinal cord has been irritated by this. And what other questions might you want to ask?
History of trauma. Do they have any like connective tissue diseases? I would maybe see like if they having like difficulty swallowing, breathing, that kind of stuff.
Sure. So yeah, do they have an underlying rheumatologic diagnosis already established? Do they have the medications? Is this causing neck pain? Do they notice a positional change in any of these of their complaints? These are all very valuable things to kind of sort out. I guess let's say this patient was in Dr. Poliak-Tunis's clinic and was just complaining of neck pain. How would you counsel this patient?
So if we had these imaging, I would then send Than Brooks a message saying, hey, you need to see this patient. No, but I think it depends on what their symptoms really are when they're coming to our clinic, right? If they're just complaining of axial pain and you're doing an exam and you're finding all these other things, right? You're thinking in the back of your head, okay, I need them to go see somebody else. But, if they have myofascial pain from, mechanically what's been going on, can we just do some trigger points in clinic? I think that's completely reasonable. I would see what underlying diagnoses they have to make sure, has Dr. Bartles or somebody from rooms seen the patient, right? So all of this, it's not just you have neck pain. Okay, let me just focus on your neck pain. We have to kind of look at them all over too. And, unfortunately, kind of what Dr. Cathcart was talking about earlier, we don't have magical medications in our pain world, unfortunately, for these patients. So we use medications from other specialties, really, I think, sometimes to help patients. But truly, if they're not on a DMARD, which I'm not managing, and they should be, then I really do want to make sure that rheumatology is involved.
Yeah, so I think that key thing of okay, what people should be involved in the decision and are they involved? And so oftentimes if this patient comes to me, I'm going to start kind of a group in-basket message with the providers at UW Health in this case, but wherever you work, to try and get a better handle on how you should manage this patient. And so that I think is really something that's changed a lot in healthcare, is that you can communicate a lot easier. You can kind of have these group messaging management kind of things going on without having to wait for patients to go from this clinic to this clinic to this clinic, and you can kind of make some of those decisions early on. And so, then it's like, if you've established that this patient's getting appropriate treatment, the neurosurgeon has said, we don't really think this is necessarily needs to have surgery right now, then you can still kind of continue on. So it's kind of that group thought process of, okay, where are we going to go with this? And so I think this brings up a really, really important concept there. Patient's relatively young. Mohammed, what do you think about a C1-2 fusion in a patient? What's the morbidity? Even though you can do a good job doing the operation.
You're still operating next to the spinal cord as high as it gets, so any injury there is really, really.
Make sure to talk in the mic if you don't.
Yeah.
You got one. Okay. Yeah.
And then the other thing is you have the vertebral arteries in there. So there is no zero risk surgery in what we do. And this is, as high as it gets in the cervical spine. So it's still risky. My question to Dr. Bartles is, if you see this, there is no going back. And like, if you start treatment for this, the transverse ligament would not heal again, correct?
It won't. So we're going to just watch basically that distance and figure out if basically you and I are going to co-manage, but we're going to basically still put them on aggressive treatment so we prevent articular damage elsewhere and prevent cardiovascular disease and all the other things that happen downstream of inflammation.
Yeah. So I think then you could run into, let's say it's 5 millimeters of anterior posterior, and then they're starting their treatment. And the patient doesn't really have much for symptoms, then you're kind of in that gray area of fusion versus watching. And one of the things I've done in the past is do like flexion extension MRI scans, so you can actually get a better idea if there is a pannus, and then also if it is compressive, because sometimes you're not seeing any symptoms from it, but you are seeing actual mechanical compression, and the patient just turns out to be very lucky in that scenario. Because then, of course, we can think about doing surgery in that setting, but it is a little bit harder. Although truly, I think most surgeons would say that it's indicated anytime you have subluxation to just do a fusion. I don't know what your thoughts are, Cliff. Like the risk of not.
It's actually quite stunning to me what medicines have done to this patient population. To give you perspective, at my residency, we had a RA Mutilands clinic, which is just stunning. I mean, and they were all very, very well known to us. So this problem's almost gone away. We could have done an entire conference on this 20 years ago. If they hit the criteria, I'll prophylactically fuse them. This person's looking at airplanes. They're so flexible. C1, C2 is going to be fine on them. So they can be hypermobile. I guess my question, if you're going to put the microphone in front of me, is Chris, you referenced those 10 articles that talk about the medications. I confess to not following this closely, but I have a natural aversion to anything that's such a strong anti-inflammatory. And you're referencing the infection rate, which is obviously what most people doing surgery are talking about. Can you comment on any of these studies talk specifically about fusion rates with these medicines still on, the ability of the body to heal despite these being, or how long a window? Because I've always pushed for, as you probably remember, about 3 months, and it does become a bit of a battle. I simply don't know the literature on it.
As far as
How long?
Pure fusion, pure fusion.
It's a great question. So, we always say it's a great question. We were saying hold, 2 cycles. So if it's something that's dosed monthly, you could say hold 2 months before and 2 months after, which gives you your window, or which we might volley back and forth as far as you're just saying, as far as so that the surgery will set and basically we'll get new.
So they're really looking more at infection rates and
looking at the infection rate.
yeah,
So
because it is.
Yeah, that's a fair question. And then we often, also are in limbo on NSAIDs and all the other things, right? I mean, I think the flip side too is continuing the methotrexate. I think the advantage of that is it's less risk than corticosteroids, which if we get them flared, then the rescue is corticosteroids, which obviously are going to be worse for bone healing.
Yeah.
Than methotrexate.
Yeah. So I don't know. I typically, in patients like these, will use BMP plus their iliac crest and anything I can do to kind of optimize the chances of fusion. I don't know what you guys have done or what you prefer. Obviously, you've been around a while, so you've done it all.
Yeah, for this, for the C1C2, the upper cervical heals so beautifully. Occasionally we'll see big scolies, and then you're really up against the wall with these meds in terms of getting the whole thing to heal. So I don't have near as much concerns with the cervical.
Yeah.
Cliff, would you take out the C2 nerve root and go into the joint, or no need for that?
Done both, but I prefer not to.
Yeah, typically I do that pretty regularly, but I mostly preserve. I definitely like to do it if they have axial subsidence. If you can distract between a C1, C2 joint.
Yeah, if you have to take the posterior arch of one, then for sure I'm going to exploit the facet joints. But if I still have the arch, I think onlay posterior is fine.
Cool, great. Any other questions or comments on that case?
In the back?
Yes, Dan. Thank you.
Paul Anderson and I had a number, we used to have clinic at the same time, and we had a number of patients with Ehlers-Danlos or rheumatoid disease who were, we term stably unstable, who would go for years, decades with 5 millimeters or 6 millimeters of slip. So in the absence of symptoms and a responsible patient, this is something you could follow. Especially now with the new medications. And I'll echo Cliff's statements. When I started here, we were doing a transoral, every week. And I've not done one in 10 years that I can remember. So it's really a whole new world with these medications.
Yeah, I was telling Dr. Bartels I was looking for these cases, and I was like going back 16 years to find, the occasional patient that kind of had been misdiagnosed or failed treatment in some very unusual way. So I do think that's the main teaching point here is like make sure that they're getting treated medically. So this one is a 71-year-old with cervical myelopathy, and you can see on the MRI has a pannus formation at C1, C2, causing quite a bit of compression there. So I know that Dr. Poliak-Tunis is going to bow out on this one.
I did look up the literature, and there are studies that you can inject into the pannus. Again, looking to see, because I've never.
Yeah,
seen that.
curiosity.
Curiosity. You just a little, like 0.5 ml of.
What
steroid.
approach do they take to
I cannot recall.
It's got to be maybe a lateral.
Probably, but I was shocked to even read that.
Yeah.
Full disclosure. But so yeah.
The other, if it's, I mean, with the myelopathy, you're sort of you're in a surgical bind, but I would say that if you didn't have if you were if it was mild disease, you actually, if the patient was on methotrexate, you actually might withdraw the methotrexate and put them on biologic, because methotrexate makes nodule formation, and the pathology in a pannus looks a lot like a nodule. So I'd probably put them on biologic to see if they thin the pannus, just medically, if you had 2 months to watch it.
So this actually, I know I put myelopathy. This actually is a patient of mine recently came to my clinic, was not myelopathic, but they did have this incidental MRI done and sent to get a further workup because she had no diagnosis of rheumatoid or CPPD or any of those things. So that was another point about this case is that this was the de novo diagnosis for this patient. And so made sure that we looked into that, although we did not find any of those diagnoses. You can see the CT scan here does not have kind of that calcified capping that you sometimes see in CPPD. And then of course, everybody would be shocked to see the neurosurgeon getting hand x-rays, but
Way to go.
winner. Yeah. I got congratulated over the years. I have a couple more cases like that, but so I think when we look at this case, we're thinking about if the patient is myelopathic, a surgical approach. So that puts Muhammad on the hot seat. What do you think?
Yeah. So
Let's say positive rheumatoid factor, getting treatment now, still has these symptoms.
yeah, I would start posterior, especially that there is no significant symptoms. I would start posterior, occiput to C2 or C3 fusion with a C1 laminectomy, and watch closely with repeat MRIs. If it's regressing, nothing else. If it's not or becomes myelopathic, then fused from the back, then you'll have to do something from the front.
Sure. And why do you think occiput?
Because I will remove the C1 posterior arch, so I will create a little bit. If this is caused by instability, I'll create even more instability in there.
Any other thoughts on that approach, please?
Just C1, C2, you already referenced it before, just get into those set joints and put some graft in there. The angst would be, do you need to do the C1 arch? And I certainly would if they were actively myelopathic. So, but the occiput to C1 level, I would kind of respect as being uninvolved and try to preserve that motion.
Okay, yeah. So yeah, I think there is, that pros and cons of doing the OC fusion versus the C1-2 fusion. Other thoughts from anyone else in the room? Jim?
Yeah, I hate occipital fusion, so I do C1-2 here, and I take an extra small BMP in each facet if I'm assuming I'm doing the C1 Lamy.
Yeah, okay. And then anybody for transoral on this one? Historically that was done, but then we started to identify that in rheumatoid, the pannus will resolve with fusion. So it's important to keep that in mind. It depends on the underlying diagnosis, whether or not you might have to do a transoral. If it's a rheumatoid diagnosis, your chances of having a resolution of the pannus are pretty high. So it's worthwhile just to do a posterior approach without the associated morbidity of the transoral. Yeah, that's why I got these hand films here. I know you were out of the room. I got a thumbs up from the rheumatologist. Yeah.
And it looks clean. So
Yeah.
Erosions at those MCPs or PIPs for RA and no chondrocal at the wrist, which is where you're looking for it for CPPD.
Yeah, so
Great
that's
question.
it's a good one. This is definitely a board's question, BJ, because it's easy to test. Okay, so you might get one there. All right, this is a good one. 96-year-old man with progressive gait imbalance and weakness. He's a farmer. He said he was still lifting, 150, 200-pound calves until he was about 88, and then it got kind of worse and worse. I made the mistake of turning to the nice old elderly woman in the room and telling her your husband will need a surgery, and she said he's my dad. So, this one was a more urgent thing. He came to the hospital, so I think again, Dr. Poliak-Tunis is free from this one. From a diagnostic perspective, let's see, BJ. What else should I do?
Hand x-rays.
Nice, nice.
No, flexion extension.
Yep, and hand x-rays. So CT.
Yeah, CT.
Again, that's just looking for CPPD.
Don't think so.
And so this one was interesting. I thought there was a lot of compression. Sorry, let me go back to the MRI scan. You can see it's kind of surrounding the cord on that axial. So I didn't necessarily want to wait for resolution of all that. I did not do a transoral, but I did a C1-2 fusion, or I did an occiput to C4 fusion, and then really took down C1, the C2 nerve roots, and then reached underneath the dura, because you're kind of reach around the dura at that point, and was able to remove a lot of that pannus so that it would decompress. So
Did you set it for pathology or so?
I did. I don't remember now. It's been a long time since this case, but it didn't come back as any kind of tumor or infection or anything like that. But yeah, certainly you have that all those concerns doing this. I don't think it's going to get any easier for you, Mohammed. I'm sorry. Okay. So now we're going to skip the interventional pain and medical treatment for this one. And go straight to the surgical / deformity expert.
Yeah. Myelopathic, I assume.
Myelopathic, positive sagittal balance.
Does it move on FlexX?
Let's say, I don't recall right now, but let's say it does not move.
Yeah.
And we're talking about not just C1-2, but also the,
Yeah.
the lower part. Yeah.
Well, it depends on also her risk tolerance, because she's kyphotic in the mid cervical region in there, but you can still see some disc lines like what you see with severe
She's
degen.
been skiing the Berkey until this last year.
Yeah, so
I made that up. But
no, but like if
hand.
you want to align her neck again,
Yeah.
you need to give her lordosis there or do a 3-column osteotomy, which both of them are very morbid. But if she is willing to go through it, then I would do a front back on this, do a 3-level ACDFs and those 4, 5, 5, 6, and 6, 7. And then this would be, unfortunately, she has stenosis all the way just underneath the foramen magnum there.
It's not a chordoma. This was a
Degen. Yeah.
pannus
Okay.
also. Yeah. Yeah.
Yeah.
Good question though. Yeah. I can see other neoplastic reason for that. Yeah. Yeah.
Yeah. And then it would be occiput to T2.
Yeah.
With the decompression.
So bigger problems sometimes, depending on the scenario, bigger solutions. Obviously, you always want to prioritize from the surgeon's perspective, decompressing spinal cord, nerve roots, things to maintain function. But secondarily, if there's deformity as part of the issue or it's going to be made worse by the operation, you have to keep that in mind too, and sometimes can escalate into a much bigger operation just because of that. So great. Well, we are back on time. Thank you very much, everybody, for coming.
I have one quick question for our rheumatologist. It just wasn't very specific to, so it's pretty common, I would say, on the neurosurgery service that we have somebody up from the North Country who hasn't seen a doctor in 60 years and they got picked by their cow and now they have an ankylosing spondylitis fracture that, we are making that diagnosis because we are the first people to see the bamboo spine. Obviously, their neurologic recovery, fusion, et cetera. But what else can we do as an inpatient when we're seeing this initially, other than, some basic workup things that you would like to see before we refer them to you guys? If this is, a new patient, how can we be of more service?
Blood testing, things like that.
Well, yeah, it's a great question. So I would say, when we're thinking spondyloarthropathy, that you can check a B27. It's positive in 15% of Caucasian population. So that may be helpful, but I mean, you already know the diagnosis, so I'm not sure that's super helpful, but you can, get your CBC, your creatinine, your LFTs, because this patient's going to go on therapy with us as soon as they're cleared by you. So, so get them in queue. I'd say have them seen inpatient. That's our wait time right now is 60 days. We're trying our best, and that's down from 120 days. So we'll get them in as fast as we can, but if you get them seen outpatient, then they're connected with us to get back in as soon as it's clear.
Yeah, that was going to be my next question is what's the wait time? So it sounds like an inpatient consult would be helpful.
That's helpful. Yeah, right. And then also I would just say, like any of these cases, obviously they fast pass to the front of the line when they've got severe disease like that too. So give us a call and we're happy.
So, yeah, sending a message.
Send us a message.
Send a message, and
Yeah.
that can
Wow.
help speed things up. So yeah,
otherwise, yeah.
perfect.
Great.
So all of the speakers that are still here, let's try and get a photo in between while we're doing a break here. There will be two more. Dr. Tribue will be speaking after this, and we'll go through some complications as well. But if we can get everybody up front so we can get some photos, that'd be great. Thank you. And of course, there'll be a educational networking event from 5 to 7:30 later on. Just reminding everybody. Okay. Everybody can come on back in whenever they're ready. We're gonna get going with. It's my great pleasure to introduce Dr. Cliff Tribue, who's been actually trained one of my fellowship mentors, and so he's been around a while, and so I even though I was a resident here, I also heard a lot about him when I was a fellow in Cleveland, and so it's great to get a lot of experience. He does primarily deformity surgery, which is a lot of big operations and a lot of challenges. And I know he's learned a lot throughout his career. So I'm hoping that he can, in this lecture, teach us how to stay out of trouble. So I really appreciate that. Thank you very much. Thank you.
Good afternoon, everybody. Thanks to Than, Bob, for having me here, and Janelle for herding all the cats, because this is a tough thing to put together. This is an interesting exercise for me this past week, kind of going over things, how to present this. I've been told, I've been told that unsolicited advice is an act of war, so I will respect that. I hope not to proselytize up here. But the key word in this title is that word learned, because I'm not so sure I have. There was no master plan to my career. I'm not recommending that. There are those that really have done it better. But in the end, the final answer, I don't know if I've learned anything. I've experienced a lot, that's for sure. So I think you'll get a flavor of that from this talk. There's a slide that kind of caps off or starts a lot of talks. It's disclosures of industry relations and journal relations and things along those lines. And we tend to blow right through it pretty quickly. I assure you, if you are involved with these things, you have biases towards them, and you really need to be mindful of them. I don't think there are too many in this talk, but they have been profound in my life. This talk, though, is not cogent. It'll be random. And it is not peer-reviewed, and intentionally not that academic, to be candid. Here's the biggest disclosure of my life, my life. I get paid to do this stuff, as many of you do in the audience here. But what does that mean? You, a patient, will come to see me. You're hurting. That's a huge disadvantage. I evaluate. I'm going to order those tests for you. And then, by the way, I'm going to interpret them and tell you what I see, try to put your story together with your x-rays, make recommendations, all without any supervision, really, except for, God bless them, the residents and fellows who are really bright and kind of keep us in line. I really appreciate that. And then I'm going to operate, and then I'll get paid. All that regardless of that ultimate outcome. And that's a fascinating problem. We're immersed in our field, and therefore probably completely unaware of our biases. I'm going to show this. This lady was in my clinic literally yesterday, and it really got me thinking, and I wanted to put in this talk because of the way it made my head spin. If you're not in the orthopedic world, I'll point out that these are hips. They are really, really arthritic hips, kind of end stage in our world, and pretty much home runs in the surgical field if the symptoms match the x-rays. This also is her spine. She's got a degenerative spondee there. And by the time she came to see me, which was the second physician taking care of her, she was actually having some bladder problems from this stenotic problem. So here's what was done originally. This is about 3 years ago. And as you might imagine, with these other confounding variables, she did not get the great result that she was looking for. And that surgeon kind of perceived her persistent lateral hip pain and leg pain as being predominantly coming from her spine. So she showed up in my clinic, and ultimately I did this. And saw her back yesterday, 9 months out. And she has not had a happy experience since day one. That includes her hip joint and my experience with her. And it's been very consistent. She was literally kind of mad at me, told me I promised her things that I didn't deliver on. And she is scheduled for her right hip replacement next week. Unbelievable ethical dilemma, because she is now 0 for 2 on 2 of the most predictable outcomes. I hope we all agree. I don't think I'm shooting from the hip here. And I didn't know what to do. At first I'm getting, you can feel yourself getting mad because she's mad. And like, no, she's still sharing with me her experience. So I apologize for any words that I gave of encouragement. Said, you were an outlier at this point, at least I hope you are. But what do you think about next week? And we started getting that conversation. Well, what do you mean? I'm going to take the advice of my physicians. I said, well, you're 0 for 2. and it left at that. And it's not in a pleasing way. And the only thing I could think of to do was to call that treating doc. And it was not ironic, as you might expect, it wasn't the original surgeon that did the first hip. It was another colleague. So I called him just to discuss it because I didn't know what to do for him or her, to be honest. But the bias I'm talking about here is this just looks like it should work, and it doesn't always do that. So I'm going to go on a little bit here, and I will get to spine, I promise. But being a spine surgeon can, in many ways, define your life, and that's good and bad. But protect these things. Some of us, we normalize a work ethic that the rest of the world, not to say we're unique in this, but a little bit, and it can be all consuming. This is a diagnosis, and it's self-made with some help of some professionals for me. In its extreme form, you can walk around and having 2 parallel lives and just blithely go back and forth between them and be actually very happy, artificially so, without realizing the wake you're leaving behind you. It can be useful in spine surgery. I'll give you an example. If you're in the ER seeing a young person who just got paralyzed and the family's there, you're sitting there chatting with them, and it's horrific. There's a little bit of stunned, like what's going on, deer in the headlights type of look amongst the family. And you've got to kind of absorb that, share with, initial prognoses, et cetera, and then within 10 minutes walk up to the OR and perform an operation with that chaos in their life in your head somewhere. And compartmentalization kind of goes, okay, I gotta store that over there for a second. That's our own little defense mechanism, but you really want to be very careful about it as it extends past your work. This is a term that I didn't come up with, but I embraced very early in my practice, spinechiatry, with the again bias that I was applying my ability and skill set to my patients and trying to discern their pathology, when in fact they weren't the only one in the room that had some. So I was told by my mentor that I would paralyze 4 people in my practice, and that was not inaccurate. I won't bore you with those stories, but I like to think I at least learned from each of them. But they are profound, and you have to offload this stuff somehow. UW is actually doing a decent job with some of the things we have, but recognizing in yourself that you have that issue is a challenge, and then reaching out for help. But if you want to start a nice exercise and habit, start at your home, share this stuff with your spouse, share with your colleagues. I got a call literally last week from a former resident struggling with a large deformity case that he took on. He's doing spine here in the state. And I think in the back of his brain, he was calling to ask my advice on how to do, what to do next, et cetera. But as I got more into it, it was 20 minutes later, he's crying because he's not sleeping. It's actually just tearing him apart. It was really eye-opening to hear. I know right where he was. So we spent the next 20 minutes kind of talking just about that. And that's really important. This is a great book on the right, by the way, if you ever have looking for something light and airy to read. It basically talks about traumas in life and what we do if we don't offload this stuff. It just sits there. It's going to come out somewhere. That's all I can tell you. Body keeps a score. So I went to school at Hopkins, and that's where residency starts. A little segue into that. When I was there, it was still very much the culture of the place, remarkably so. Developed the modern residency back in the late 1800s. It was a pyramid system. You'd have 12 residents show up. They'd be there between 6 and 8 years, but only one would finish. And the term resident comes from the fact that these people lived in the hospital often months at a time. They did not have any home lives, and it was just brutal. Did not foster kindness. Does anyone know who Libby Zion is? Yeah, very good, very good. Yeah, Libby Zion, I'll tell you briefly. Libby Zion was the daughter of, I think, of Sidney Zion, who was a lawyer and a very well-known writer in the New York metropolitan area. She came into the New York ER late 80s, I think it was, got Demerol in combination with her MAO inhibitor and passed away. And it was blamed, not universally accepted, that it was related to long working hours. Dad kept writing letters and op-eds in the Post, and eventually became the Bell Commission, which became a 80-hour work week, which is now all over the country. One person. So I won't go into mentors because frankly, I've not used them very well. I hope you find them, do use them. You can see careers really made by those relationships, both in advice and support. I had a different ability to take mentorship into my heart back in the day, but I still remember things I was taught. One of them, all of dermatology. This is really important. This is if you're a dermatologist, if it's wet, dry it. That is the lesion that you're looking at. If it's dry, wet it. If they're not on steroids, put them on steroids. If they're on steroids, stop the steroids. If you don't know what it is, by God, don't touch it. If you do know what it is, you don't need to touch it. So very practical information for dermatology. General surgery, I learned there, eat when you can, sleep when you can, and do not F with the pancreas. Scott Cantor, now I'm in HSS, PGY5 to me is PGY3. Cliff, please help me as much as you can without actually leaving the operating room. So that's my mentorship. And, when I came here, I was introduced to anger management. Mercifully, was not experienced in it firsthand, but this is a better way. Except when you have turnover time, you might want to use this quote. This was a mentor at HSS. I don't know what it is around here. Ignorance or apathy. Don't know, don't care. Anyway. A couple more social thoughts. How would you like to know that your spine surgeon's in over their head in debt? That's not good. Avoid memorizing CPT codes. Why these two things? These are biases. If you know what you're going to make per every procedure, it's going to affect the way you think about that. I can guarantee you CMS knows that. They change those codes all the time because they can literally track our behavior by those codes. It's fascinating to watch. If you've ever had the opportunity to go to a meeting in Washington and watch those things kind of form in the open discussion, it's quite fascinating. This is free unsolicited advice. Max out your pre-tax contributions, just make you feel better. You don't have to have one job. Perhaps one of your passions can be monetized. Okay, on to the spine stuff. Spine stuff can be really fun and really rewarding. So this is a gentleman, 34-year-old guy, came in with ankylosing spondylitis, had sought me out, and really highly educated about what he had and what he was up against. Described for me, I think I needed an osteotomy. It kind of went on and on. So here he was. I want to call your attention to the creases in his stomach because this is actually going to evolve into a story. So that's what we did. And the technique of this was, since he was autofused all over, the upper screws were all put in perk. The lower screws I did open to put in the sacral fixation, and then did an opening to do the osteotomy. So I was on the patient, I was standing on the patient's left side, finished the ostomy on the right side, working on the left side, had a little Penfield 2 down the front of the spine as I'm taking my wedge out of the lateral wall. Everything looks great, ready to close it, take the Penfield out, and all heck breaks loose, if you will. It's bleeding like crazy. Put the Penfield back down there, it stops. So now I have a dilemma because I've got an anterior bleed, I'm posteriorly, and I've got stems from the perc screws sticking out. I can't flip the patient. So I take some Surgiseal, I pack it down in there, close my osteotomy, and kind of hope. Called vascular in to kind of explain the situation. Can I see? Move the Surgiseal. Okay, enough of that. I've seen enough. There's literally nothing anyone could do with that particular wound. So finish the case. 2 hours later, closing, call vascular back in. What do you think? We've been monitoring SEPs and MEPs, et cetera. I mean, monitoring crits, and it seems pretty stable. So we had decided to take him directly to the ICU for kind of a trauma protocol, serial crits, and that sort of thing. So the next morning I walk in, and I'm a little shooken from this experience, and he's just kind of waking up and getting used to his day. And he kind of shakes my hand and sits up a bit. And as he's doing so, the nurse fluffs up his pillow, and he lays back down without the pillow there. And for the first time in a decade, he's lying flat on the bed. He starts crying because he's happy about this. And he looks up at his belly, and those creases now are wide open, and they're all kind of gummy and nasty. So 2 people at the complete opposite ends of the spectrum. So I'm like, I'm glad you're breathing. And it's just a strange field. That's why I bring it up. So good and bad of almost all these cases. So your practice will change throughout your career. This is a pet peeve, but your diagnoses unlikely are they're going to be the same. Okay, so this is 20 years of degenerative spondylolisthesis. All those different procedures I've done for the exact same diagnosis over time. I have my personal favorites. I was quite smitten with the X-stop. Very sad to see it go away. But here's kind of a fascinating thing. Can you? So that's 2006 through 2010, I believe. Upper right where the red is, that's the X-stop. That's as big a percentage as that was. Bottom right is the purple is decompression fusion. Thanks very much. And this kind of brown was T-lifts. So I was doing a ton of T-lifts for these operations. Okay, whoops, now what's it doing? Can I advance it? Okay. So this is more recently. X-stops essentially went away. T-lifts completely went away. The big purple now is still my kind of traditional open decompression fusion. And that left kind of taupey color, the big one is ASF PPI. So all diagnoses of degenerative spondylos at L4-5. While on the topic of degenerative spondylos, if you think about extending to S1, this is a pearl, if you will, I would ask you to please reconsider. How about if it's bone on bone and they say they have back pain? I would still ask you to reconsider. Think about how this etiology came about. What brought that person to your clinic when they came in? So they might tell you, my back's hurt for years, and that might even be a degenerative disc at L5-S1, but they came in with stenosis symptoms. And once you fuse to the pelvis, your cascade of junctional disease is going to be escalated substantially. So your spondy developed because your 5-1 disc was stiff, and that's how it came about. And then you got stenosis and you got neurogenic claudication. So that's really how you want to minimize this. Even if you're hesitant, I would ask you just to try it. Seriously. In fact, I find very few reasons to fuse to S1. Isthmic spondylos, no choice. For those, though, think seriously about going up to 4. Preserve as many levels as you can. As a deformity surgeon, I can tell you there's a bias of fixing these things. I have a reverse bias. What's the smallest one I can get away with? If you have a deformity and they are globally coronally imbalanced, that's almost a mandate to go to S1. Very hard to correct without going to S1. Primary degenerative disc disease in a young female, rare thing, but that's a primary 5-1 level. Failed herniation, also pretty rare, frankly. Degen scoli, the kind of the poster child for our field right now. Really a benign condition, remarkably benign condition. You'll see 5-1 discs involved all the time with them. They don't have stenosis at 5-1, very rarely do. It's almost always a 3-4 and 4-5. So try to avoid that. What brings on new markets? No one's out there channeling new patients into my clinic. It's all the same people come to my clinic. But there have been little blips through the years that kyphoplasty was the first, actually probably degenerative disc disease was kind of the first one. But kyphoplasty kind of, I don't know how many spine surgeons are still doing kyphoplasty. I'm certainly not anymore. That was just torture. But the BAK was a fascinating one because that started interbody cages. We had femoral rings predated it, but in terms of putting implants in, BAK was a cylindrical cage that would be placed either through an ALIF or PLIF. ALIF surgery was not that common back in the day, so people who come from posterior, she'd put this thing from a posterior side, and it just spawned an explosion of interbody. And yet the very diagnosis for which it was designed has almost gone away, but there are over 900 products that have been approved that are interbody cages by the FDA to this point. So an enormous explosion of instrumentation when the diagnosis itself has evolved to other things. So if you see a new innovation, just ask yourself if it makes some sense. Now, I can't be critical just because we're looking retrospect. These were best options perhaps at the given time. That being cemented corpectomy, that was usually in tumor type surgery back in the day. Even as they came out, just abhorred the idea of PEEK rods. I had a product on the market called Trio. It had a ball ring around it, and the company that I was working with asked me if they would like to put PEEK in it because it was an ideal way of using PEEK because the ball ring would just cinch around PEEK, but it seemed like a pseudoarthrosis machine to me, and I really didn't want to be tied to that product. ID BAK T-lifts, that's basically a kyphosing machine. Here's an example of that. So if you take a round thing and put it in from the back, your best hope is it ends up being parallel to the end plates. And this was just a 3-level that had a pseudo at the middle. The answer to me was just take the pseudo out and do a PSO and try to keep the construct short. Errors in spine surgery, undertreatment, overtreatment. I like undertreatment. If you undertreat somebody, if you do a decompression degenerative spondy and they recur 6 months later, I don't love that scenario for a patient, for sure. And I fuse most of my degenerative spondy, as I've showed you. But that's better, in my view, than doing a 4-to-1 fusion, because now I've got rid of the symptoms. They went away. I know the back pain probably improved already. And then they come back with the same symptoms. Well, now you go back and fuse that level. Not advocating that, fuse it right off the bat, but undertreatment is something you're going to figure out pretty darn quickly. Overtreating is way more insidious. The body's incredibly resilient. You can throw amazing stuff at it, and if you catch somewhere in that the true pathology, you might even have a happy patient. But we're paid to operate again, and this is a pet peeve, the epidemic of T10 to the pelvis fusions. So fusions themselves have gone up. That's not a big surprise. People are aware of it. They seek care when they're hurting. I can't blame medicine on that. And it's going up as we get older in an older population. So that's not surprising either. This is the one that catches my eye. The massive increase in elderly population, 4.5-fold increase in a decade of the number of T10 to the pelvis fusions. That's an amazing number. And there's not an increasing incidence of degenerative scoliosis. This is the type of thing that's being normalized. That's a 47-year-old person that could write out of the European Spine Journal as an example of doing a PSO. PSOs were described for ankylosing spondylitis and post-fusion problems where you had a 3-column fusion, so you just do a PSO and close it. This is a degenerative spine with open discs. A PSO in that's going to be a pseudoarthrosis machine again. And you ask yourself, pre-op, post-op, what have you really done to this person? I no idea. So why? Just because you can, not really a good idea. So having experienced this evolution in my career, I've tried to figure out why the heck it happened. Surgical decision-making is a huge conflict of interest, as I've alluded to. So are we doing it for financial reasons? God, I hope that's not the case. Belt and suspenders, there's another hypothesis. You're a true belief that you're doing the best for the patient. I think that's certainly part of the equation. But this is really, philosophically, how did this happen? It may be hidden in the way we teach, the way we talk about radiographs, the way we hyper-scrutinize balance and measurements and things along those lines. Because just think about this. So on the right, you see a turnbuckle cast and a risser frame. That's scoliosis treatment. If you had a daughter, that would look pretty barbaric, right? So why did this field of spine surgery even evolve? there are people out there that have a problem that no one could treat. So you get these early pioneers that are embarking on trying to figure this out. There's a lot of gain for that patient population, no question. Now these surgeons are developing these skill sets, and did I mess one? Hold on. Yeah, so as those mentors were learning their skill sets, and one of them was my mentor, he's 90 years old now, Dave Bradford, and he was thoughtful, gifted surgeon, not overly aggressive, even back in that era. Did his own research, read the research, was a leader. That's probably, you're starting to get into the sweet spot for patient, physician benefit to both sides. So as we get further into this, now you have surgeons trained in this, and not as many patients need it, and you get this mismatch. And you could argue that there's more gain for that surgeon. So here it is. This is what I was alluding to. I forgot I had the slide. So you have this deformity. Some of them, not all of them, are symptomatic. The pioneers learn how to treat. Patients are a little bit of a guinea pig as in the early. If you got a Rizzer catch or you got a turnbuckle cast, you certainly were not state of the art, but you were at that time. Continues evolving, margin gain high and increasing. Next generation outcomes, radiographic parameters, complications, outcomes probably peaking at this time for patients because you got a good match between numbers. And then it just kept going. So then you have the next generation learning radiographic parameters, criteria somewhat applied indiscriminately without truly understanding the patient needs. And I do think that's part of this. So the skill set supersedes the patient need. So again, the poster child, degenerative scoliosis, ubiquitous. 50 plus, 68% of the population have some form of it. You're seeing in this. The vast majority not symptomatic, and if they are symptomatic, it's almost always the stenotic component to it. So the i.e., the deformity is rarely, very rarely the problem. Definitely happens, but it's very rarely the problem. Here's a lady I saw in my clinic a little over a year ago, remember her well, 63 years old, and she was demonstrative to say the least. She talked about her back pain. So the question is, was this the first time she encountered a surgeon to ask about her back pain? Turns out not. So the x-ray is a wonderful thing about PACS is you very quickly have access to their history. And going back and looking, say, oh, look, she got an x-ray in 2007. Again in 19, again in 14, again 15. So now what's the problem? Now I have a progressive curve. And you might say, well, now I got my answer. The question in my head is, why did she get that first x-ray? Go back and look on the chart. Very dramatic, same pain pattern. I confront her with it. I go, can you tell me the difference between that pain pattern and this pain pattern? Absolutely not. That is a surgical red flag. So is her curve related to her pain? No idea, but I certainly wasn't going to throw a huge operation on to try to prove that it was. So how do you measure pain? Really hard to do. Here's spinechiatry for you. If a 25-year-old guy with a spondee walks in your clinic, wants it fixed, don't. How do you measure it? I had a former fellow who was pretty creative in the way he thought. His idea was to take the equivalent of a guillotine with a weight on it, and you'd release it from a set height, about 18 inches, and it would drop on your fingernail. And so he's trying to quantify a pain source. I'm sure there have been others try it. I thought that might not get by the IRB, but it's kind of clever. Good news, think about yourself. How often would you go to see a physician for pain? I'm post-op. It took me a while to go see a doc, about 3 years before I just said, got to get this thing addressed. There are a lot of instruments, but ultimately, if someone's in front of you, you have to figure out what their function is. You can't measure that pain in a meaningful way, in my view, to make a surgical decision. Ask them, well, do you like walking with your spouse? Can you keep up? What sports, what activities have you literally given up? And if you start getting in that, I can walk 2-3 miles, you might see that pretty commonly in a 50-year-old with stenosis because they'll kind of figure out how to get through that. But as you get into 65, 70, they won't go. That's a different population. So anyway, while we're on the subject of pain, fibromyalgia, that is the bane of our existence, makes me a bit nauseous for sure. And I like this just because you have fibromyalgia doesn't mean you're not crazy. But think myelopathy. It's a great masquerader. It's kind of the syphilis of spine. It's just, that's a segue. So here's an example, 69-year-old lady with a curve, but she presents with claudican symptoms. She's telling me about her walking intolerance, sitting intolerance. Yes, she's got back pain, plenty of it. Look at that 5-1 disc, arthritic as heck. But how long's this curve been there? A long time. Coexisting with it beautifully. Why is she in my clinic? She's in my clinic for her new onset stenosis. Therefore, and she did get improvement with her ESI. So there are some ways of teasing this out. She's got stenosis of 4-5, and that's the limit of what we did. And you can see on the left, that 5-1 disc is still arthritic, and that worked out just fine for her. The costs here are laughable in terms of an index case. You can see that just calculate dollars per screw. But the human cost is potentially a whole heck of a lot worse. Probably everyone in this room knows or has heard of PJK. It was a non-existent diagnosis when I started in practice, did not exist. People have made entire academic careers writing about it, describing it, trying to prevent it now. If you don't do a lot of T10 to the pelvis, you're not going to see a lot of PJK. Because if you look at that X-ray on the left, if I'm talking to that patient preoperatively, I actually have to talk to them about spinal cord injury. I have to. They have to know what they're up against. On the right, not even part of the conversation. So pseudoarthrosis, kind of called a pearl or what have you. If you have a patient, you've done a degen or a scoli or any type of fusion type operation on them, and you see them back, this is the critical part about seeing them yourself back in the early post-op period. Why? You want to see how they're doing. You had this enormous assumption of where their pain was coming from. That's a commitment in and of itself. They are committing to you and you to them. You want to know how they do early. Was your assumption correct? That neurologic pain should improve. Their back pain should improve. Spinal hardware is quite stabilizing. So if they're doing well and 4, 6, 8 months later they come back and say, Doc, something changed, you get the X-ray and go, oh, that looks pretty good. I don't see any problem with it. Still, in the back of your head, don't give up on the idea of a pseudoarthrosis. This is an extreme example of one, but this was a 14-year-old gal who, these are X-rays of her post-op. I don't have pre-op films. Sent to me after the next X-rays. Did beautifully. 6 months post-op, back pain starts coming up. Appropriate CT scan done. Whoops, where's the CT? There's the CT. Thin kids, so they go, you know, it must be hardware prominence. Hardware's taken out. And that's the problem. So now a pseudo progresses to deformity. Now you've got a bad problem. You actually bluntly had a bad problem to start with. I will show you what I did to this just for yucks. So this was an L5 resection. There's really no way to pull that up and over. You can't shorten the sacrum enough to pull that over safely. So went in the front of the spine to take out the L5 vertebral body. Then posteriorly, you can see on the left, I think, pulling what is now L4 back onto the top of S1. S1's been shaved off. And once it's back there, I didn't think I had enough surface area to get a decent shot of the fusion, so I actually flipped her back over. I did an anterior, posterior, anterior, and put a bunch of bone in the front, just lay it in there and scuff things up. And once she healed, and I instrumented up to L3, so once she got a year out, I went back and took out the L3 screws and the iliac screws, and left her just with a 4-1. Okay, your patient will teach you and tell you what to do. Please listen. So this is a lady that I operated on when she was in her 70s in 2013. Did what I just told you I hate. Showed up in 2022 at age about 83. And I don't know if you can see it, but right at the junction, right there's a broken rod, okay? So broken rod is the essentially radiographic equivalent of a non-union. And I threw these cases in because I've been collecting them. And this lady's CT scan is as you see here. And I can assure you, I tried to get some cuts without videoing it. The thing was as solid as could be. So now I have this issue. This lady has been doing great, hurts like crazy, very specific in her pain pattern. and is now flying in the face of something that I don't believe exists. So Chit Renawat was referred to, I think Mohammed mentioned him earlier, most gifted surgeon I ever saw actually at HSS and since, just passed away at age 90. Just a wonderful surgeon. They had a ton of isms, so this is one that actually most of us probably heard some variation of. The eye does not see what the mind does not recognize. So I'm looking at this, I see it, but I'm like, but I knew this lady very well, as I hope to with most of my deformity patients. And you can see on the right, I cut out the broken part and just spanned it, and literally better in the recovery room. It was really fascinating. And I've got 5 now intact fusions with broken hardware, 3 of which I've operated, all similar, and 2 of which I'm currently watching. And I think it has something to do with BMP fusions, to be honest. I think there's, as people get older, there's a mismatch between how strong the hardware is and how wimpy the bone is. Not much you can do about it. All right, I got one more case here. What is the essence of spine surgery? Humbling as can be, better teach vigilance, empathy. I think about this a lot. You get in, you're behind the 8 ball with a patient. You've got a complication, you're wherever you are. What's going through that person's head? Some you're going to lose. They'll go to a colleague. I'll facilitate that if they ask me about it. But an awful lot of them just flat out double down with you. And it's just stunning to me. I don't know that I have that much faith in my mankind, but they will do that. And here's an example of a person that I've worked with for a year and learned more about from her and just kind of goodness. Her husband was with her all the time. They were a little rough around the rough, but boy, they were supportive of each other and it was just great. So she comes in as when I'm first meeting her, whoppingly big 70+ degree curve, pretty strong lateral aesthesis at that 3-4 level down the bottom. So we did talk about surgery, and this is what I took her to the operating room the following February. And I wanted to reduce that lateral aesthesis, so I did go anteriorly at 3-4 and put in a femoral ring. By the time I flipped her over, she proved to be so mobile that, and I even put a kick-out screw in the front that she jumped her femoral ring over that. I thought it still had enough context, so I kind of left it there. That is February of 2008. So 6 weeks post-op, she's kind of hanging in there. You can see that graft on the lateral. You can see a little better. It definitely, I think the screw head is in the middle of the ring of it. But it's incidental in her life, and I'm not going to expose her to another anterior, so I kind of watch it. So that is April of 2008. She gets back pain now in August of that same year. Enough so, again, a change. I'm thinking, oh, she's got a pseudo. That ring didn't work. Get a CT scan, and I see a fracture of that pedicle. She's not particularly interested in going back, so we actually watch it, and she does fine. Whatever, I assumed it healed because 3 months later, she's feeling better. That is November of 2008. Here is 3 months later. Now she's fully 1 year post-op. I'm feeling decent about it, but I do notice that subtle little spondy forming down at 4-5. She's not having pain, so I do still think that fracture is healed. I'm suspicious enough, I send her to genetics because she, number one, had a really mobile curve. I don't normally get that much correction from these things. And she got a pathologic fracture very quickly. Her genetic workup was fine. I still actually don't believe it, but it was fine. Here's 2009, shows up in the ER with cauda equina. So she's taken that night to extend her fusion down. So there's 4-5 being incorporated in the fusion. Still a nice healthy disc at 5-1. And that was, what's that, April of 2009. Here is August of 2009, pathologic fracture through L5. That's kind of sad. That's not one I was going to watch and have the same thing happen to her, so I actually did fix that. Now she is, what, a year and a half out from an index operation extended down the pelvis, which to me is just miserable. That is not the end, however, as you might imagine. So she comes in now later, actually the subsequent year, and she's lost a lot of weight. She's actually thriving. She's doing pretty well, but she doesn't like, she can feel the hardware when she sits against a hardback chair, and she is asking to have hardware removal. So I do a CT scan. It all looks good. I was a little nervous about the 5-1 just because it's the pelvis, and I didn't want to take that hardware out, but took all that hardware out, and on she goes. So that is August of 11. Increased mid-back pain 6 months later. Boom. So your open disc at 11-12 is now a leverage point for what is a BMP fusion. I alluded to that earlier. I think the fusions are kind of wimpy. This is one of the ones that taught me that. And sure enough, breaks right through that. So that gets harder out, harder in. This is the vicious circle. I have no idea why this woman never got PJK. I never wanted to go back near that top. I didn't want to touch anything, but I had to go back up there a little bit to put the hardware back in. This is where now. So that is 12. We are 4 years later. So I think I'm winning, and she. This is where fool me once, fool me twice. You know the stupid thing. She does not like her hardware. Hardware out. There's a solid fusion, interbody fusion, robust fusion in the back. Hardware out, partially because I'm stupid, but not that stupid. And what happens? Boom, breaks right through the TLIF. Hardware in. This is 6 weeks after that. And this is the last time I saw her other than routine follow-up. Ironically, on my birthday in 2017, so 9 years later. I respect what this person went through. I won't applaud my own vigilance. It was exhausting, but you got to listen. So I didn't talk too much about kind of the smallest operation get away with. I alluded to a little bit with teasing out just stenosis in the setting of degenerative curves. But you really want to ask yourself when you're looking at deformity, how much is the deformity truly the functional issue? If you've got flat back and you're pitched forward and your walking tolerance is a half block, you got a problem. So then you fix the functional deficit. If you're standing with positive balance with some neurogenic claudication, your positive balance is 2 inches, do a decompression, they'll probably stand up straight afterwards. So think along those lines. So some summary thoughts, because I got lost in the mire here a little bit, I'm sure, so I didn't want to revisit some of them. L5S1 is your friend. Keep it moving. Don't fuse there unless you really have to. Again, if your patient's doing well, think pseudoarthrosis is your job to prove that their fusion is solid. You owe that to them. If you're going to fuse someone, particularly short segment, I didn't talk about this at all, but it's really important. It's important for degenerative spondylosis, important for isthmics, 3 to 5s if you're doing. That's why I love ALIF and PPI. You can get a lot more local correction and restoration of lordosis from the anterior interbody. A poorly performed TLIF is a really bad kyphosing pseudo machine. That's why you see almost none of them in my spondies anymore. I think they're great for MIS, great for 1 levels, but they have issues. If you're going to do deformity, you have to commit fully. Your patient's got nowhere else to go once you commit to that, but don't do it alone. Jim and I have started doing some cases together. I love it. It makes me happy. I hope he's happy. I had a very bad complication about 5 years into my career, and a team approach was mandated by the hospital. I was like, oh my gosh, thank you so much, because now I have a real excuse to go out and solicit help, and anesthesia team, critical care team, the whole 9 yards really changed my life and that of my patients. This was, I talked to my colleague that called last week, this exact issue. No situation so bad that can be made worse by another ill-conceived operation. We want to help, we want to fix, we see things on the film. It's amazing what the body, PJK is kind of the poster child for this. You don't need to fix every PJK you see. Neuro, run, get in there and get it done. Anything else you can kind of watch and let it prove it's going to fail. If hardware loosens at the top of a construct and you're seeing junctional problems up there, you're getting nervous, just remember the hardware is no longer doing anything. And you can watch that natural history over time and make it fail before you go back in to do something. Watch ligamentous PJK, particularly approximally. If you see that you want to jump on. So if you're starting to angle without fractures, I think that's more dangerous. Listen to your patient, they'll tell you what to do. So I love this one, damn the anatomy, stick to the bone. Thank you for being here. Appreciate it. Thanks.
Thank you, Dr. True. That was a just wonderful talk, tour de force.
Yeah, it's good. You did great. You did great. So I guess I'll kick off questions or comments. The issue of bias, right? What our job is in the surgical side is to do the surgeries that we do. And of course, we can escalate them. There's a lot of, even as we saw today, you can decompress or you can fuse, you can throw an implant in there or not. I think that does have a major impact on us. You see a very different version of how spine conditions are treated in Europe compared to the U.S. So I think it's an interesting concept.
Oh, God, yeah.
Your
No,
thoughts?
I'll expand a little if you like.
Yeah.
Narcotics in our country versus other countries, unbelievable. I mean, now we got a problem. We're swinging the other way. I was going to get a knee replacement in September of this year because I had a horrible flare of knee replacement. I talked to 6 surgeons, sports, joints, and a cartilage doc. Sports said, I had a cartilage defect, and it was acutely flaring my knee. So I wanted to ski, so I was going to get something done quickly. I was scheduled for the knee replacement. My joint arthroplasty docs, with the exception of Rich Ilgen said, go see Brian Cole. Brian Cole's a cartilage doc down in Chicago. I'm like, I'm too old to get my cartilage fixed and repaired. And these are friends, people who I love and love me. So they're giving me their opinions. So I'm scheduled. I've got my 3 arthroplasty surgeons say, you need a uni, all good. I call Brian. In Brian's world, metal and plastic in the knee is an abject failure. His comment was, number 1, you have no idea why you're hurting right now. I was only 4 weeks in. I'm like, ooh, that sounds like me speaking. And bottom line, there's his bias. His bias is not arthroplasty. All of them cared for me. All of them wanted me to do well. But my surgeon, by protocol, put me on Celebrex. 3 days later, I'm going, ooh, this is getting a little better. The cartilage piece probably broke off, causing some synovitis. So I thought to myself, all right, 5 weeks, I'll lay low. Last week before surgery, I'll push it. And that'll be my failure. And 2 weeks later, I said, I'm canceling the surgery. This is going to get better. So it's fascinating. And that's just what we do bias. That's insidious as can be to me. That's really tough.
And I talk to patients about, they get their MRI report, they go on the internet, they look up what the diagnosis is. The vast majority of the information talks about a surgical treatment or something like that. Rarely is it a non-surgical treatment.
Yeah.
And so by the time they show up in our office, they often have a bias too.
Yeah.
They know what they want.
We love that.
Yeah. And so then, that, like I said earlier, if I'm trying to talk you out of surgery, you best listen because I get paid only to do it. Right. So I think that's an interesting part. And then the educational bias is if you have a fellowship, you rarely are having a fellowship in boring old general spine surgery.
Mm-hmm.
You're only gonna have a fellowship that is like this special piece of spine surgery, and so therefore your fellowships have a higher risk of training people that are trying to do stuff that don't need to be done. So that's
no. I have the hammer and the nail.
Yeah.
Cartoon in a lot of my talks, and where to go, and there's a nail driven in behind you. I just sort of whack. It's real.
Yeah. Anybody comments? Mohammed, anything?
Really appreciate it. Thanks much.
Yeah. Thank you. Okay, we've got a little bit more time. We want to talk about complications. So we'll get that up, and we'll do 1 or 2 of them.
I feel I did enough of that.
Yeah, exactly right. Any other questions or comments while we're doing some IT work here? APPs, anybody? I'll make a comment for the schedulers. We have that challenge of scheduling people when they're on anti-rheumatologic medications. We have to find that gap. That's why we're messing around like that. That's usually trying to find that 2-week period after they stopped it, and 2 to 3 months, 2 weeks to 3 months until we can start it again. We've just got a couple cases with some associated complications, which I think we'll
make everybody stressed out enough to want to go to the bar later. So I think that it's worthwhile. Kate Bunch is a fifth-year resident with us and is looking forward to a spine fellowship at the Cleveland Clinic. So we're excited to have that. So hopefully this will be some food for thought as you guys are going through your lab tomorrow and thinking through what kind of anatomy you want to be careful with, how to avoid these kinds of complications in the future. So thanks, Kate.
Thanks, Dr. Sorry about that. No surgery was offered at that time. It was recommended that he follow up in 2 years and continue with PT. He didn't make it 2 years. He made it 4 months when he had new numbness, tingling in the hands and feet, difficulty swallowing. Of note, he did have a new diagnosis of multiple sclerosis that had been recently made at that time. And given this, he elected to seek a third opinion. Here is his MRI at the time that he was seen during that visit. So you can see he continues to kyphos forward. Here's his CT. And of note, he's lying down for these scans and he's this kyphotic. So that's another thing to keep in mind is his position during these scans. So he self-referred to UW. This was his message that he sent us when he said, he notes that he had a laminectomy. He says that my cervical lordosis, he means, has been reversed and I have difficulty swallowing. He's not in the medical field, so when people start throwing around kyphosis, lordosis, and they're not medically trained, it's a little bit of a red flag for me. Obviously, this person has been through a lot if they already know these terms and they are able to more eloquently describe what's going on. At the time we saw him, he has a diagnosis of celiac disease. He was formally diagnosed with ankylosing spondylitis, GERD, his multiple sclerosis. He has hepatic fibrosis, anxiety, and depression. His current physical exam, he's 5'5" strength in his right hemibody. His left upper is a 4+ in the delt, 4 out of 5 buys, tries, grip. Left lower, 4+ out of 5. He has sensation intact, and his deep tendon reflexes are reasonable. They're 2+, negative Hoffman, negative Babinski, no clonus. I wanted to include this picture. I didn't for HIPAA reasons, just because I really wanted you to be able to see his eyes and his chin, but we did lay him down in clinic and he's not able to lie flat. He's really lifted forward, but I didn't feel like I could accurately show you without violating his HIPAA. So what would you do? He's saying he's miserable. He has horrible swallowing difficulty. And he's neurologically reasonable, but he's now seeking a third opinion because he really feels like his quality of life is completely unbearable.
Well, I know this is, it's obviously too late to do anything about this now, but if you go back to his original MRI scan and the exam you described,
yeah,
it's way out of proportion to that.
Exactly. Yeah.
So I think that was one of the first things that I noticed about this image was like the stenosis is not too bad, and you described pretty bad myelopathy kind of picture. So thoughts on that? Let's see. That's what I think. Yeah, I think it was probably MS from the beginning. And,
yeah, we don't have any MRI brains from back then.
Yeah, or any workup, so that always the cautionary first mistake is to do an operation when they don't need it. So that's a tough one, and then maybe for the wrong indications. So okay, now we go to the deformity. So like chin on chest.
Pretty much, yeah. He's very, very kyphotic.
With true ankylosing spondylitis.
Yes.
Yeah. Okay. I don't want to talk about it. Gives me heartburn. Mohammed.
Yeah, so I was the one who saw him in clinic. Like, he is miserable. He's only 42. He's on disability now because of all of this. He was like a normal guy for all of this. Obviously, he has a new diagnosis of MS and so on, but his deficits from the MS are really minimal. I believe most of his left-sided 4 out of 5 weakness is from the MS. No active lesions found on his spinal cord or his brain. They did the CSF test and they found some markers that they said he has MS. He cannot see a person above their chin, so he can only see a maximum of the neck or chin, and he's always walking like this. Now he can't eat or swallow well. So this is something for thinking about if you can do anterior posterior, like basically you can't swallow well. So my opinion, I told him and I discussed him in a peace conference we had as well, is that, we have to do something. It's progressively getting worse. Every single scan that Kate was showing is getting more and more kyphotic. He's only 42 and it only gets worse. Yeah, so I know already what we discussed, but I want to hear what others would do.
Well, certainly like chin on chest deformity is quite debilitating. Obviously, I presume you got some Scoli films and stuff like that to help sort out.
He's getting more scans today.
Yeah.
He probably got them by now.
So, yeah.
Yeah.
Much can pull them back, like with strengthening all of those muscles back there? Is it significant or is it not?
I think it depends on the underlying diagnosis. So ankylosing spondylitis is very much like, you know, you're getting fusion of each vertebral segment. So it's a little unclear what PT and those types of kind of corrective procedures will do. However, you know, if you have a patient like this and you're seeing them very early on in their course and they're not kyphotic yet, that's when you can gauge those kinds of things. So the first time I met a patient with ankylosing spondylitis, they were a neurosurgery resident, but they decided to quit neurosurgery so they weren't looking down holes their whole life. So, yeah, because they were worried that they would become kyphotic from their job, so that they would have to deal with this later on. So those are things that you can kind of think about, you know, not necessarily just during the day, but most people will sleep. They'll get a pillow under their head, they'll get kyphotic, and then they'll just keep jacking it up with pillows over time, and that will affect them. So
Would you tell this guy to become like a ceiling painter?
a neurologist. I wasn't in neurosurgery at that point. That was when I was a medical student, but it was just an interesting thing that they had decided they'd self-selected themselves out of it after they got this diagnosis, so that they wouldn't have to potentially have to deal with this. So, and then the laminectomy, you know, may have, of course, accelerated that even in a normal person. So that's.
And the picture Kate was talking about, like it's a lateral bit. So I asked him to lay down on the bed. I took out the pillow, and obviously you need to make sure that they're not going to injure the spinal cord or anything. He's very rigid, like his bones just like that. So his head is almost like 90 degrees off the bed, and he's fixed. He can't rest his head.
Yeah, so those cases, of course, you're generally you're going to be stuck doing an operation. It's just a very dangerous one. Yeah, so
Yeah,
which is what the C7 PSO was invented for.
Yeah, so the outside hospital, you know, they're not super excited. It's very clear from their documentation to offer him any kind of surgery. But if they said it's going to be a giant front back, they're talking about multi-stage over at least 2 days, gradual connected procedures. They warned him he's going to need G-tube feeding, et cetera, et cetera. So pretty massive surgery. I know we discussed him at spine conference. His uncovertebral joints are all fused, and he's obviously very, very high risk for swallow difficulty. He's already borderline needing a G-tube per his primary care. And so ultimately, when we discussed him at our multidisciplinary case conference, we were thinking about potentially doing everything from the back to try to avoid this, because otherwise you're going to be doing that multi-stage surgery as well, sort of a less is more approach to try to get him back to something reasonable, but try to decrease your swallow risk as much as possible. Obviously, a long segment fusion down to T2. Obviously, this complication, this post-laminectomy kyphosis, this is not like news. This is a Mumineni paper from 2003. This is a well-established sequelae. There's several factors that are associated with it. Obviously, a preoperative loss of cervical lordosis. Resnick always says that life is a kyphosing event. So if you're already a little kyphotic, then your risk of that is even higher. Facet capsule disruption due to some of the biomechanics I won't get into here. But the more of the posterior tension band that you take, the more that physics can pull you forward. Obviously, there's oncologic radiation considerations, the age, the number of lamina excised, and the best treatment is prevention. You know, I was going to talk about this, but Dr. Brooks already did. Did he even need, you know, this decompression initially? Was it related to that with such little stenosis? Could he have had an ACDF instead? Could he have had a laminoplasty? Or they could have just fused him up front. So he's continuing to get his workup. He's going to get preoperative swallow evaluation and optimized as much as possible. His A1C is close to optimal, but not quite there. before this correction occurs.
I don't, Dr. Bartle.
Discussed that it's a three-column osteotomy. UIB is going to be C2, LIB is going to be T5. Now, the debate was whether C7 PSO versus T2 PSO. C7, there's always the risk of, having C7, C8 palsy. In this case, he loses his hand, which would be a big thing for him.
Yeah.
So he's coming back to clinic and discuss with him T2 PSO versus C7 PSO.
Yeah. Definitely, I believe to go in that direction.
Yeah.
So I would say even a one, but two is probably one that's still one with you. Yeah.
Yeah, trying to get away from the functional nerve roots if you can, and then also, I don't remember exactly what his Scully films look like, but I seem to recall that kind of the beginning of that curve was lower than the cervical thoracic junction. So these can be pretty challenging cases because sometimes it's both their lumbar spine and their cervical spine are both problematic. So you have to you cannot fix one without fixing the other to get them functional benefit. But I don't know, Dr. Bartles, I don't think is here still. It'd be interesting to know what kind of treatments may be coming out for ankylosing spondylitis, because obviously, historically, just like rheumatoid, it was more like we were just watching the disease progress over time, but now we're seeing these kind of medical changes that may have an impact. So again, another important patient to make sure that they have a good rheumatologic management as well for the long term. Great. So this is like a complication before it becomes one.
Well, the complication occurred, but we'll see if we
Not your complication.
if we add. Yeah, that's what I'm saying. Best one.
Yeah. I think that there's nothing, in one way, you have a patient like this and you're of course, happy that surgery worked out, but of course, the biggest complication was doing the surgery at all, I think, because you put them at risk without any benefit.
Brad ended with a cute picture of his kids, so I added my spine mentors. I've never had a better scrub tech than Dr. Brooks.
Yeah. Oh, yeah. I'm great at handing instruments. Hey, thanks. Great.
Make sure to turn it
I hope everybody else did today. I really appreciate all the speakers coming and giving us their input and residents putting together these cases. I know these are fun. We're not berating you when we're talking about the surgeries, by the way. So we've got again, we've got our educational networking event later, 5 to 7:30. Whoever wants to come. Turns out there's a bar in the Fluno Center, so we're going to use it. And then we will see everybody else tomorrow for the lab, which will be a great time. Make sure to get some good night's sleep. So thanks everybody.